In a world where carbs are your enemy, you need one man to help you fight your battles. That man is Jimmy.
Combating nutrition disinformation and general bull. It's Jimmy Rants. JimmyRants.com.
What's up, you guys? Welcome back to another Instagram Live. We're here with a special edition of Jimmy Rants. JimmyRants.com, by the way, is the website. We are in a doctor's office, and I'm a little bit later because I did tell you it was going to be 1:15 because that's when the doctor told me I was going to be. And but we're a little bit late. That's all right. We are here live in the doctor's office of that man right there, Dr. Gus Vickery. You might remember him about a month and a half, 2-ish months ago. That pretty lady got her health numbers looked at. So today is Jimmy Moore's day to see what he's doing well and see what he's doing that needs some areas of improvement. So Gus, take it away.
Yeah. Hi, everybody.
DrGusVickery.com, by the way, is his website.
Yeah. We're going to have a good time together going through a lot of interesting data, the kind of data that most people would probably enjoy getting about themselves, but unfortunately they're not always able to get, which really tells a complete story about how a body is functioning. And we're able to put that together with what Jimmy's doing, the changes he's been making, and some of his dietary approaches, and really get a sense of what's serving him well and what areas we can further improve. And it's a lot of fun to do this because the end result is somebody really knows the story of their body and how it's functioning, and then we can move into optimization, how to optimize function and measure that subjectively and objectively. And when people are working off of an optimized functional status of their body in all systems, lipid cycles, metabolism, inflammation, oxidation, nutrient levels, hormonal optimization. When you're looking at it holistically at all systems and someone's able to optimize, it's amazing how good they get to feel. Our bodies are designed well, they're designed for health, they just need the right information. And this type of information helps us to know what's the information Mr. Jimmy here needs to feel his best. So let's go.
Let's do it.
Yeah. So when we walk through this data, if you saw Christine's, you know we're going to spend a while together and we're going to be looking at each set of data and we're looking at it from the perspective of what is the story it's telling us about Jimmy's body's function right now. We're not looking at it from the diagnosis of diseases. We're just looking at it as data points that help us have an understanding. So we're going to talk about each one. We're going to talk about what it could mean and whether or not we need to do anything about it. And at the end, we'll summate. We'll kind of tell the whole story and when we put it all together. So the first thing we ordered was a standard cholesterol concentration. I always order these on patients primarily to get the triglycerides, and so I can look at triglyceride and HDL ratios. But as we know, cholesterol concentrations are not the best way to look at actual cholesterol. What we want is particle distributions, and so you can look at particle distributions and sizes and get a better sense of what is going on with someone's lipid cycle. Are they moving more cholesterol out to the periphery? Are they moving more back for recycling? And are they clearing cholesterol well? So when we look at Jimmy's data, what we see is this total cholesterol was 289.
Which is lower than it typically has been. It's been in the upper 300s.
Yeah, so his cholesterol has lowered with the program he's been following. His LDL concentration was 230, which actually correlates well with his LDL particle count of 2,249. So that, in this case, the actual concentration is fairly accurate. We see that his good cholesterol is 52 based on just a concentration, and the triglycerides are excellent at 65. So we like that triglyceride HDL ratio. That's already one data point that already makes us a little less concerned about his total cholesterol or the LDL. Now, when we look at the actual lipoproteins, we look at ApoB. Of course, ApoB travels with the LDL. There's one per bundle, so it's sort of a surrogate marker for how many cholesterol particles you have. And then we look at the actual LDLP itself, and we see a count of 2,250, which, of course, based on...
Which has been a lot higher than that, too. It's been as high as 3,700.
Yeah, so that's if he was up to 3,700, he's down to 2,250. That is a major shift.
Yeah.
In fact, more of a shift than you could probably make with cholesterol-lowering medication, which we're not recommending for Jimmy in this case, and we'll talk about why.
And Jimmy would never take again.
That's right. Yeah. And then when we look at his pattern, he has small LDLP. So
that's higher than it's been. So that's a change.
So you had
it typically is under 500.
Okay, so you did have a shift up in the small.
It's shifted up, which could be an inflammation thing, which I know we're going to have a common theme here today.
We're going to have a theme about inflammation. That's exactly right.
Yes.
And the HDLP is actually much lower than the HDLC. And so in this case, his HDLC is a little bit misleading because his actual particle count is lower, which means his HDL bundles, as you probably know, are smaller HDLs. And what we want are the bigger, fluffier. That's how it's described. Again, there isn't a good or a bad cholesterol. Cholesterol is cholesterol. It's a vital nutrient for the body. It has many important functions, including synthesis of steroid hormones, maintenance of cell membrane integrity, anti-inflammatory properties, healing properties. We need cholesterol. We shouldn't view it as some sort of noxious chemical that somehow our liver just synthesizes in a rogue fashion. But nonetheless, we see that the pattern of the distribution is a less favorable one. LP(a), y'all probably know about that, and Jimmy probably knew that he has LP(a).
That's about double what it's been before. It was 220 before,
and
so it's 478 now.
And it's felt that it also is more of an inflammatory response lipoprotein.
And that's one of the things, at least from the people that I've talked to before, that it allows you to fast more readily, having a higher lipoprotein(a). Is that your understanding?
I don't know. I don't have expert knowledge of that. I know
the experts that I've talked to
but I do
said
know
it makes you more able to, and I've been doing more fasting lately.
Yeah, well, I myself carry LP(a), and I can fast very well. So there's a study of two right there.
Anecdotally, anyway.
Yeah, but LP(a), it does vary based on what's going on with your lipid cycle, but it's also genetic, right? If you have LP(a) or you don't. Those that don't have it don't make it. The reason it's measured is that LP(a) has an association with an increased risk of stroke. A significant increased risk of stroke if you carry LP(a). It's not thought that the lipoprotein itself causes the stroke, right?
Yeah, it's just a marker that says if you have this, you have a high propensity.
Yeah, it's a corkscrew-shaped little bugger, and it actually acts like fibrinogen. And fibrinogen, of course, is involved in coagulation cascade and blood clot formation. One theory is that from a more of an ancestral perspective, that this would have been a favorable lipoprotein in individuals who were more subject to injury or predatory attack because your blood would have clotted faster, you would have had an enhanced inflammatory response and healed faster. And that does kind of make sense given the way the lipoprotein is shaped and the job that it does. We don't directly lower LP(a). We don't have any treatments. At one point, high-dose niacin was proposed for that, but it's hard to tolerate and we didn't get good outcomes. So what we really do is look at the overall, again, particle distributions, and then we're going to move into inflammation in just a moment. And we really focus on reducing inflammation because that seems to be
that's the key in it all.
That is the key in it all.
Right.
Right now, of course, one of the working theories with atherosclerosis is that actually, of course, the LDLP is there to repair. Right.
That's why it's higher.
That's why it's higher. And the LP(a) would also be showing up there to repair.
Makes sense.
Yeah. And we know from Jimmy's prior evaluation for actual atherosclerosis, looking for plaque, that he had a coronary calcium score done twice. And what was that score?
0 the last 10 years.
0 over the last 10 years. So at this point, he hasn't formed plaque with this history of this.
Although the argument will be no hard plaque.
Yes.
But it might be soft plaque. Is there any concern of yours about soft plaque?
Well, you said you had a carotid IMT.
I did, CIMT,
Yeah. And did they mention any plaque deposition?
no plaque.
And so if you look at it the way the studies we have to evaluate plaque, one, coronary calcium scores, they're excellent because you can really get an objective idea of are you forming calcific plaque. If Jimmy had not had one, I would definitely be recommending it based on the profile we see here today. I would want to, because if he was a plaque former, that could change our recommendations. And this is some of the people who practice in this area of medicine would say no statin ever. In my in cases where I have patients who have moderate to severe stenoses in coronary arteries and high inflammation and high oxidation, I will use statin medicines. I still see evidence that they might be protective for those individuals.
But it's the last resort, not the first treatment.
Yeah, it's after lifestyle. Right. After we do everything else with lifestyle. More than that, we would focus on insulin resistance.
Right.
Yeah,
of course.
Still. But yeah, I still see a role for statins in patients who we have objective evidence of plaque. But the coronary calcium score can only tell you about calcific plaque, which is really healed plaque or hard plaque. And IMT will give you evidence of both plaque formation and, of course, a measurement of the intima media, and that thickness is correlated with the arteriosclerosis, atherosclerosis process. And the other thing that an IMT does, and people often don't look at this detail, it'll actually characterize any plaque you see on the surface of the artery. So you might not have any significant buildup, but you might have a layer, and they'll call it either soft, heterogeneous, or homogeneous. Homogeneous is calcific plaque, it's healed. Heterogeneous is mixed plaque, it's healing plaque, and soft is fresh plaque. And so you can use IMT along with a coronary calcium score so you can see, am I atherogenic? And I had one patient, he was a smoker, high blood pressure, very bad dyslipidemia, high stress, and he was 50, and we did an IMT, he already had 50% carotid stenosis, now that's some major plaque buildup. And he also had an advanced panel, he had inflammation, all the other stuff we see. He addressed each risk factor, quit smoking, lowered stress, took blood pressure medicines, and 3 years later, we saw 1, no plaque progression, stable. 2, all characterized soft plaque had turned into homogeneous plaque. And so that would indicate that the process had healed and that he was no longer in a pro-atherogenic state. And so that's kind of what the goal is. Biochemically, it could appear that Jimmy is in a pro-atherogenic state based on what we're seeing. But he doesn't have a history of it, and he didn't have soft plaque before. So we're not really thinking of this really primarily from atherogenesis. We're really looking at it from optimization of his function, so he can feel it be as healthy as possible. So anyway, we see that he does have a lipid cycle right now that would suggest perhaps inflammatory response, healing response.
Do you guys think I'm inflamed? Duh.
Yeah. Now I always check oxidized LDLs. I will tell you that we don't have great interpretations yet, and because of the style of the test, the type of test that they use, it's not necessarily an accurate measure of total oxidative stress burden on the body. There are other tests that can assess that, but they're a little bit esoteric and harder to get. But I still use it because you can, if you look at it and you look at a ratio of how much LDLP is there, you can get an idea, is there more oxidized LDL than you would anticipate based on the actual LDLP level. So if it just correlates, because the more LDL you have, the more that you're going to have an elevated level of oxidized LDL. Right? But if you had a very low LDL level, and a very high oxidized, then you got a problem with clearance of lipids or enhanced oxidative stress balance in the body. And in Jimmy's case, it does still favor that oxidized LDL of 119 does suggest that either one, the lipids are staying in the system longer than they should and hence becoming oxidized, or 2, there could be some balance of issues affecting oxidative stress, and we're going to walk through those as we go through this test here. Yeah. All right. So our next section, we got into some inflammation, and I'm using 5 different markers. One is a high sensitivity CRP. Most people are familiar with it. Most pop culture articles have said check an HS-CRP if you have your doctor check that as a vascular marker. It's okay as a vascular marker, but as we know, it's highly sensitive and not specific. Right. If you had dental work, your CRP goes. The
high sensitivity C-react is highly sensitive.
It's highly sensitive.
He's a funny doctor.
It's even labeled as such. I had one patient who went and did the most intense workout of his life and then came in for this test. He hadn't realized, and he had a CRP of 15. Yeah, which is an expected response. Of course, I think that's too much inflammation in response to exercise. I think he worked out too hard. Right. But anyway, so we have a CRP. And it's mildly elevated, 1.6.
It's the highest it's been since I've started keto.
Yeah, so his CRP has gone up.
It's been like 0.7, 0.8 most of keto.
Yeah, so in this moment. Now, one of the questions I would always ask is around the time of the blood draw. Have you had an infection? Did you have dental work? Did you have an injury?
It was the first week in July, and we've been traveling quite a bit, so that might have been a mitigating factor.
Yeah, so that could have influenced it. Had you just started one of Trent's intense workouts?
No, I haven't been on and I wasn't flipping a tire yet.
Yeah,
so.
okay, yeah. Well, we also see some other markers. I mean, basically all 5 markers are either in the intermediate or the higher risk range. So LP-PLA2 and myeloperoxidase, these 2 are very specific intra-arterial markers. So I'm looking at these as potential risk of endothelial inflammation or inflamed plaque. Like if I knew that Jimmy had already had a significant amount of plaque in his arteries, and he had those cholesterol distributions, and he had very high levels of LP-PLA2 myeloperoxidase, I'm starting to get concerned. Okay, is there an unstable situation going on in the arterial wall? But so we definitely see elevation with each of those. When you have a high level of LDLP, LP-PLA2 will sometimes run with that. So I like to look at the 2 of these together. And then fibrinogen, right? So we already talked about how LP(a) is a fibrinogen-like lipoprotein. The fibrinogen levels are also very high. Right. And then homocysteine, which is an inflammatory mediator, but it's not really as much of, we're looking at it as a as a product of inflammation. It's more of a source of inflammation.
It was right on the borderline of optimal and intermediate.
Yeah, and so homocysteine is one way of assessing nutrient deficiencies such as folate, B12, B6, and riboflavin. Homocysteine is also one way of looking at methylation.
Is that what that's going to help with?
Yes, that's what that's going to help.
This is what I'm taking now because of that. Yeah. Homocysteine level.
And when we get to the nutrients, you'll see why. Yeah. When I see an elevated homocysteine, I always have questions about, is that person do they have any impairment in their methylation pathways? Most people have at least some impairment based on the MTHFR gene variants, and I
have one,
and he has one. So, but it can be overplayed a bit, right? Like not everybody is necessarily undermethylating, but if you see high homocysteine and issues with B12, perhaps, you will know that person is, probably having some impairment in methylation. Methylation is a very important biochemical process. It's an anchor process for detoxification, genetic expression, and energy production. So if you are having a significant impairment in methylation, all of those pathways are going to be impaired, and you're not going to be optimized. And homocysteine is one potential marker for that. So our focus on homocysteine is one, we need to possibly improve methylation, because an impaired methylation cycle impacts detoxification, which could impact oxidation. It all ties into each other. And we also don't want that elevated homocysteine triggering actual inflammation in his system. And then the other inflammatory markers, we have to really look at them as, what is creating this inflammatory response right now? Why is Jimmy dealing with inflammation? And some would say, it's because he's gone on this other diet, and that's probably what's doing it. And in some cases,
referring to keto carnivore.
Yeah, keto carnivore. And in some cases, depending on a person's genetics, it could, right? Maybe in some individuals, depending on their genetic blueprint for their eating, it's possible that higher saturated fat or more protein could be triggering inflammatory responses. But in Jimmy's case, we actually were looking at the totality of the data, and some things are a lot better than they used to be.
A lot of things are really better, as we're going to get to in a minute.
Yeah, and so what we don't know, because he hasn't done this in a while, is what would this have looked like 6 months ago? Yeah, and so we're not trying to fudge and make it look better than it is. We're going to deal with it straight up.
Take the good with the bad.
Take the good with the bad, but this is a baseline. So what we're going to really be curious to see as we outline his plan, what happens over the next 4 to 6 months, because we're going to reassess this data, and we're going to know.
After the sabbatical, too. That'll be interesting.
Yeah, and we have a holistic plan so that we can really address it. So at this point, the inflammation is not alarming me, because I know his arteries are healthy. So I'm not worried at this moment about, oh my goodness, he has inflammation, he's about to have an arterial event. There's the possibility that what he's done, he's lost some weight, right? Didn't you say, Jimmy?
Yeah, almost 30 pounds.
So he's lost 30 pounds. Right?
Since May.
And does some of that feel like it was visceral fat, not just subcutaneous fat?
It's all there.
Yeah.
It's all from there.
And when we get to
my arms are skinny, my legs are skinny, it's all visceral fat.
Yeah. And so we do know that when someone is beginning to liquidate visceral fat, that we actually will sometimes see some enhancement of inflammation or some increase in inflammation.
Is it because of the release of the toxins that were
in
the
cytokines,
fat stores?
toxins, all of it, yes. Yeah. So people can actually bump their markers, and we'll also...
Temporarily.
Yeah, temporarily.
Until it's flushed out of the
system. Until they're flushing. And then we also we'll see an increase in inflammation, oxidation, possibly. Some people, if it's just a small amount, we don't see that. And uric acid, we'll see uric acid go up. And of course, if part of Jimmy's blind spots that we're going to reveal here in a moment, including possibly the methylation issue, if his liver isn't detoxifying well, then, and you're flushing visceral fat and you're flushing cytokines and and toxins, then you're retaining those, you're going to be triggering more inflammation.
Right.
Yeah. So
makes sense.
Yeah. So we hope to improve those processes. But it's important if you want to look at your inflammation, get a more comprehensive view than just a CRP if you can. Get more specific markers. Now, the next one is endothelial function, and that's where we're trying to look at.
It's one of the better ones, so let's talk about this one.
yeah. It's when you're looking at, the lining of the arteries, the endothelium is one cell layer thick, just like the gut lining, the enterocytes is one cell layer thick. It's a living dynamic surface that's engaging with your bloodstream. You've got different types of white blood cells and protein, all kinds of receptors lining that system, engaging what's going on in your bloodstream. And nitric oxide release impacts endothelial function, the ability for the vessel to dilate. So nitric oxide communicates, and you relax the smooth muscle, and the vessel dilates and opens. It's what happens with sexual function issues, blood flow to the brain, blood flow to the muscles during exercise. As we age, we will lose some nitric oxide function. We produce less nitric oxide. Erectile dysfunction medicines work by slowing the breakdown of nitric oxide in the synaptic junction there in that area. That's part of how they work. Some individuals will have genetics for nitric oxide function. They actually do not synthesize as well, and they end up doing better with a diet higher in nitrates, not nitrites, not nitrosamines, but nitrates. And there are clear genetics that you can get that will tell you whether or not you might need some help in that area, because you could eat nitrate-rich foods and use supplements like L-citrulline, arginine, beetroot, and you can actually improve nitric oxide synthesis and function. So we're looking at 4 different markers, and there's basically, and I won't name them all out right now, but
They're a bunch of $1 million words. Just know that.
A bunch of $1 million words, including L-arginine. But overall, three of these markers are looking really good. They're in the optimal level, and then the asymmetric dimethyl-arginine ratio is very slightly elevated. So the overall assessment of this is endothelial function is pretty good and healthy right now. We're not looking at endothelium that appears to be, inflamed and compromised in some way. Yeah, which is good. There might be some slight reduction in its ability to respond to nitric oxide and dilate, but it's slight. So I'm happy with that result for now. Again, if I look and I see dysfunctional lipid cycle and I see high inflammation, especially intraarterial, and then I see this in the red for endothelial function, I start to become highly concerned.
But mine's all green.
Yeah. So he looks great in this area. And then we did another test that I think everybody should...
This was interesting.
Yeah,
I love this.
Yeah, everybody should have this done at least once. Because you're looking at your absorption of stanols and plant sterols. And these are the molecules that we use to make cholesterol out of. And then you're also looking at the markers for your synthesis pathways. And so rather than just simply saying, you have high cholesterol, you shouldn't eat as much cholesterol, which we now know really is a completely bogus take on the whole thing. I
like this guy already.
Yeah. We can look at how are you absorbing these sterols and stanols?
Right.
And then what is your liver doing with them? And you can be a hyposynthesizer, meaning not making enough, or you can be a hypersynthesizer. And if you have low cholesterol, like really low cholesterol, which we know has the risk associated with it. In fact, all-cause mortality seems to favor those who have higher levels of cholesterol rather than lower levels of cholesterol. I would want to know, because if I'm a hyposynthesizer and have low cholesterol, it might benefit you to get more cholesterol into your system. Ironically, exactly. But because it's a vital nutrient and important building block.
Is this a genetic marker, kind of like you do the ApoE genotype, where you're a 3-3, a 2-3, a 3-4? Is it similar to that, or would it change over time?
So this will change over time, right? And so the genetics, of course...
But you said at least once, and I was like... Does it ever change?
Yeah, and for some individuals, if they have optimal, then you know that they're probably their body is regulating the absorption as well as the synthesis in an optimal fashion. But so, and when I'm looking at things, so I also do genetic analyses for people where we look at all the different genetic SNPs that inform all the different areas of bodily function. Those are the genetics, that's the blueprint, that's the information, that doesn't change. What I call this is the epigenetics. How is the body expressing itself right now? And the goal, of course, is once you have your full genetic blueprint for your optimized health, that you then use the epigenetic data to you merge it as much as possible. That's the Apeiron, Dan Stickler, you know, his group. They've put that genetic analytic tool together. It's phenomenal.
Nice.
We'll get one of those on you guys once we. Well, that'll be our next step.
First things first. We got to get a baseline.
Yeah. So I want to stop for a moment because this is very important to people to understand. When it comes to the absorption, we are looking at not just stanols, but we're looking at plant sterols. And, you know, plant sterols are often used to lower cholesterol. Plant sterols are not what we make cholesterol out of. We make the cholesterol sterols out of a form of sterol, but it's not plant sterols. But in our gut, plant sterols and the other sterols are competing for absorption. And then once they're absorbed, they actually work through the same pathway in the liver for synthesis. So a plant sterol cannot be used to make cholesterol, but it will actually move into that same system. And so it can reduce how that system is producing cholesterol, which is why high doses of plant sterols in some individuals will reduce total cholesterol because it inhibits the synthesis because it's competing, right? But
are you guys getting smarter today? Because this is deep.
Yeah, but here's the thing about plant sterols. Just like many of the different phyto compounds in plants that are actually noxious to our system, right? A form of hormesis, as we know. They might not play a nutrient role at all, other than the true vitamins and minerals we can get from plants. They appear to play primarily the role of initiating hormetic responses that increase production of glutathione and other endogenous antioxidants, making us more resilient. And in high doses, of course, they become noxious and harmful to our system. Well, plant sterols are noxious to our system. In high levels, they trigger macrophages on the lining of your endothelium and create intra-arterial inflammation. And most people don't know this. There is a genetic variant. There is a protein that hangs out in the lining of your gut, the enterocytes, and it's a bouncer. And its job is to look at all the sterols entering into the enterocyte and bounce the plant sterols back out. Right? It wants to keep them out of your system because, one, they're not good for you, and two, they compete for cholesterol synthesis. And it lets the cholesterol sterols pass through, but it bounces the plant sterols. And this is a genetic factor, a variant that influences how much of that protein you have. Some individuals who don't have enough of that protein will be hyper-absorbing plant sterols, not just cholesterol sterols, but plant sterols. And if they are, they'll end up in a situation where they have a very high level of plant sterols. It's called siddalsterolemia, siddalsterol, along with high levels of cholesterol, and then very high levels of inflammation. And those individuals, if they have that genetic variant, are much more likely to have early arterial events. Early. And if that individual, because that's their condition, has that early arterial event, and they go and they get it cathed and they get a stent, and then they get signed up for a vegan program, right? A vegan diet is very high in plant sterols, right? And so, you know, studies had thought that maybe it's 5% of people who have that genetic variant. Based on the people who are testing that variant, it's in the profile that I do. And then looking at the absorption markers for siddalsterol, his Jimmy's were fine.
Normal, thank you.
Yeah, but when we look at that, you know, those individuals, that anecdotally, what the people who are checking that are saying 10 to 15%, that's what we're seeing. Meaning up to 10 to 15% of the population could take plant sterols to try and lower their cholesterol and actually be creating a bigger problem in their arterial system.
Right.
Yeah. So that's why you want this test for two reasons. One is you want to better understand cholesterol pathways in your body, but two, you want to know, are you a hyper absorber of plant sterols? Because if you are, I hate to admit it, there is a pharmaceutical, but there is a pharmaceutical that they tried to make popular for cholesterol lowering and it never took off. But Zedia's primary role is to inhibit sterol absorption in the gut.
Interesting.
And there's no studies on this, but the people who are testing these siddalsterol levels have identified that when these patients with this genetic variant take Zedia, they see the plant sterols all drop down. and they're not absorbing them nearly as high. Of course, cholesterol lowers, but then inflammation lowers. So there's actually a prescription that can help with that. And the diet for somebody who has acetylsterolemia would be a keto carnivore diet. Actually, by the way.
Thank you very much.
Yeah, by the way. But so when we look at Jimmy's, we see that the acetylsterol levels are normal, which is good. His cholestanol levels are actually elevated. That's an absorption of a cholesterol sterol. And ultimately what he's categorized as is a mild hyperabsorber.
Meaning?
Meaning you are absorbing more cholesterol sterols than, well, actually I can't say more than you need. Your body might be smart about this, right?
Might be very efficient at it.
But in comparison to some other individuals,
right.
You're absorbing more of the cholesterol sterols.
Interesting.
Yeah, from a population norm standpoint, rather than having them excrete through your gut.
Would that be considered hyperabsorber? Is that right?
Yeah.
Is that why maybe some of the elevation
Yeah.
in the cholesterol?
Yeah, and so your body is taking up more of those sterol substrates. Yeah, but it's not taking up the plant sterol substrates, which is good. When we get that genetic profile, it's doubtful you would have that genetic variant based on this report.
Right.
We clearly see you're a hypersynthesizer.
What does that mean?
Your liver is making a lot of cholesterol.
No kidding. I think I knew that. My whole life it's always been higher.
Yeah, we've solved the puzzle. Now, this is definitely informed by genetics, right? It's informed by, meaning there are genes that some individuals will have that create a tendency for that body to form a lot more cholesterol.
Would that show up in the lipoprotein little a? Would that show up LDLP?
So this would be your
showing up?
This would be your familial hypocholesterolemia categories.
So I had that tested from Embry Genetics when I was writing Cholesterol Clarity, and it said I had only like a 5% chance. It was like such a remote chance that I had it.
I don't think you have it. I think that for whatever reason, genetically, your body is definitely a high absorber, high synthesizer of cholesterol. And then there are other factors in play right now that are probably influencing this.
Right.
You tend to run high cholesterol you have all your life.
Yeah.
Your body is using that cholesterol. Right? It's not
doing
a disease.
something with it.
It needs it. Now, if you
it's helping with the inflammation right now.
Yeah, exactly. Yeah, more than likely. That's my working theory at this point.
Which is why I think when I lower the stress during the sabbatical time,
yes, exactly.
I'm thinking cholesterol's going down, inflammation's going down, I'm losing weight, many good things.
Yeah, if you haven't picked up on it so far, our theme
inflammation.
Our big theme is inflammation. That's what we're seeing here. And individuals who already tend to have a higher cholesterol, it's an important building block for many functions, are going to have, when they have inflammation, they're going to produce more cholesterol. Even though the LDLP is much lower than it used to be, which is great.
Yes.
We're happy about that. But again, cholesterol absorption, cholesterol synthesis. The panel I'm using is called True Health. They actually get this through Boston Health. Boston Health is.
Can any doc run it, or will they look at you like a, because a lot of doctors, mainstream doctors, these guys will tell you, they won't even run like an NMR.
Yeah.
And that's the challenge.
You need to see if you can find a doctor.
Find a Gus Vickery.
Yeah,
he does see people, by the way. Come to Asheville. It's a pretty area.
And I can do virtual encounters for people who can't find anybody to help them. Those are a little more challenging process-wise. I like face-to-face, but I have patients who work with me from other states if they can't find a doctor to get them this kind of data, and we can do that. But you have to look around and see if there's a doctor. A lipidologist, even an old school, straight up lipidologist who's looking at it from a pure pharmaceutical, they're ordering these tests.
I have no love for lipidologists. Okay. Most of them
but
think
if they'll
LDLP
get
the devil.
Yeah, but if they get you the information.
This is true.
Then you can
hold your nose and don't take their statin that they push on you.
That's right, yeah. So now this next piece of data is very compelling, and I would recommend everyone check this if they can.
Yes.
Again, you have to find someone who will do it for you. And let me just go ahead and say that Jimmy is now an official member of the 100% Club. 100% of patients who are not taking consistent fish oil or omega-3 supplementation have a deficient level of omega-3.
Yes!
Yeah. So if you cannot find a doctor to test your omega-3, just assume you're deficient. Just assume it. And we're going to talk about his carnivore diet because theoretically the carnivore diet should have a ton of omega-3 in it.
You would think.
Yeah, seafood, salmon roe.
Well, if you're eating those things.
Exactly.
And I'm not.
Brain.
We're talking about that today.
Yes, brain, DHA, right? But yeah, his index
is bad.
3.3. And that is
bad.
That's bad. It's really bad. And as we know, omega-3s are anti-inflammatory, antioxidants.
Which would infect all of those things we've already talked about.
Absolutely. There's no doubt the poor omega-3 balance is playing a role in this other data. Now, the index is actually taking the DHA and EPA, the two that are most important biologically, adding them together and wanting them to be over 8. Right? I like it to be 10 or greater, and if you have an APO...
And mine's 3.3.
Yeah, Jimmy's is 3.3. If you have an ApoE4 variant and have greater risk of Alzheimer's, I like it to be over 10 because omega-3 status is critical. Critical for those individuals, especially the DHA. When you get this panel, what I love about it is not just an omega-3 index, which for Jimmy is not good, right? It's looking at your alpha-linoleic acid, which you would get from plant-based sources of omega-3s.
ALA,
Yeah. Now, a lot of folks will try to front-load ALA as a way of getting more DHA and EPA because ALA is converted to DPA and DPA is converted to DHA and EPA. But the problem is, as we age, we don't do a great job of that conversion of ALA. And so if you are a plant-based person, if you happen to be a plant-based person and you need DHA and EPA, algae. Algae is what you got to go to. And that's
and they
where...
have a lot of iodine. There's some other element that's in algae.
Yeah, well, so plant-based, so kelp has a lot of iodine.
Kelp, right,
yeah.
right.
But algae does have a lot of, it depends on the forms, it'll have iron and other things. But algae...
Maybe it was iron I was thinking
so you can get algal oils that are high in DHA. But, I mean, I would prefer to get it from a marine-based source that was animal. Animals just have higher levels of DHA, EPA because we create so much of it. So we're looking at that breakdown. And, if you were to front-load ALA, it would be flax oils, walnuts, chia seeds. But then there's all kinds of controversy over the whole theory on some of these plants and some of the potential noxious elements of these plants.
The flax especially for men, prostate concerns and all
exactly. So I'm a fan of taking EPA and DHA, and Jimmy is now doing it. I like many different products.
Although I will tell you, open that. Smell. Is it supposed to be that nasty smelling? Because my concern is and people I've talked to, if it has a smell at all, it's rancid.
It doesn't smell rancid to me.
Okay, but you smell it.
Slightly.
Oh, I smell it a lot, and I'm a hyper smeller. Jimmy Moore does not like that smell.
Yeah, it doesn't smell rancid to me.
Okay.
And of course, if you get algae-based, if you get algae cacti,
right.
they smell totally alike. Have you ever taken the supplement Quality of Mind?
I have not.
I like it. It's a great nootropic. They have algae oil in them for DHA.
Right, and
they all smell like fish oil. Yeah, right. Exactly, and it's not rancid. I don't think this is rancid.
Okay.
Yeah, I think you're fine.
I'm trusting you on that.
So what I like about this product is actually a broad spectrum essential omega fatty acid supplement.
From Nordic.
Yeah, so it has omega 3s, 6s, and 9s, and it has borage oil, which is a good source of essential omega 9s. So it has parent oils plus EPA and DHA. And my patients who've used it, there's another company, Living Fuel Super Essentials. They also have the very similar product. They're almost identical, and I like that product too. But my patients who've used this specific supplement, we've seen clear improvement.
I've been on it 2 weeks now, so fingers crossed.
And when we get into Jimmy's diet, I'm going to recommend salmon roe and all kinds of things.
It's on the agenda. I went to 3 different stores yesterday trying to find it online.
Yeah.
All of them sold out. All these carnivore people are buying them up.
Oh yeah, I bet it is going quick. Yeah. But so this omega-3 index, and then if you look at his ratio, because we also have his omega-6 totals here, which is 36.4. So his omega-6 to omega-3 ratio is a 36:6 ratio, or a 6:1 ratio. We know that the optimals, and this varies, but at least under 3:1. 3:1 would be optimal, 2:1, 3:1. And that anything over 4:1 is a pro-inflammatory, pro-thrombotic ratio. And we saw that he has high fibrinogen and high inflammatory markers. So he is in a pro-thrombotic, pro-inflammatory state. Now, how much of that is due to the omega-6 to 3 ratio and the deficiency? We don't know, but certainly it's playing a role and it's not helping things. So we're definitely going to be correcting this omega-3 deficiency, normalizing the omega-6 to 3 ratio. As an aside, omega-6s are pro-inflammatory. The reason is that the base of omega-6 is linoleic acid, which we need. We need linoleic acid. It's converted into arachidonic acid, which is an inflammatory mediator. And so the omega-6 pathway goes into pro-inflammation, and the omega-3 pathway is anti-inflammatory. The base substrate for omega-3s and 6s, linoleic acid and alpha-linoleic acid, compete through the same system to become the next thing they'll become, either the inflammatory arachidonic acid or the DHA and EPA. And so the modern American diet, the standard American diet that's just so heavy laden with linoleic acid from seed oils, so saturates that system that you can't synthesize omega-3s. You're just not making them. So that's part of the problem. One part of the problem is underconsumption of omega-3s. You're not getting enough of them. Another part of the problem is too many omega-6s, not allowing your body to use the synthesis pathway. In Jimmy's case, I know he's into clean food. He's written a book about it, I think, How to Eat Keto Clean. So I really don't think he's pouring vegetable oil and canola oil and corn oil on his foods. And his omega-6 level is a fairly normal level. So in his case, it's just a severe deficiency of omega-3s. And we're going to correct it through supplementation, but we're also going to look at his diet.
Right.
Yeah. All right, so on our next page, we've got a lot of different metrics, and things get a lot good here for Jimmy. We're kind of happy
Finally,
about,
right?
Yeah, some of this data. Jimmy will give you the context of his prior data. This is the first time I've looked at his data. Fasting blood glucose, 97, so under 100.
Typically, it's around like 100 when it gets run fasted.
Yeah, and so, there's a lot of misinformation. I mean, people who
And it's a morning reading.
Yes.
So it's higher in the morning.
Yes.
I'm wearing a Freestyle Libre right now, and it's probably in the 80s right now.
Yeah, so, if your blood sugar, again, if you have looked at these other markers and they look good, and you happen to have fasting sugars that run between 90 and 100, don't worry about that. And the A1C, the insulin levels, these are the things that we need to look at it in context. It's glycemic variability that's the major influencer. I think I have a pretty good cortisol response in the morning. I wake up with a lot of...
You wake up. He wakes up.
Yeah.
That's a good cortisol response.
It's about 10 minutes. And I've been playing around with a meter that I got at PaleoFX, and I hadn't been testing. But
what?
For glucose and ketones.
Okay.
Right? Because I follow not a standard ketogenic diet.
But you would be in and out of ketosis.
That's right, because I tend to fast most of the day.
Right, and that would put you in ketosis.
And I'm still low carb, right? That's still my diet is a low carb diet.
He's not anti-keto.
Yeah, no, and I cycle into a full ketogenic diet for about 6 weeks every winter because I believe in the benefits of that. But what I found is that my fasting sugars are usually between 90 and 100, but that my overall range throughout a day, pre, post meal, what have you, stays between about 85 and 110, and almost never goes over that.
I hate it.
Yeah, and my A1C was 4.8, right, and insulin was 3. So I'm just more distrustful now, especially people who are following, say, ketogenic diets and low carb diets and fasting protocols. Of a fasting blood glucose that falls in this 90 to 100 or 105 range. We want the other data before we start saying, that's a problem.
Right.
Yeah.
And the 5.3 A1C is actually a little bit higher than I've been. I've been around 5.0, 5.1.
Okay.
Pretty consistently. I think I hit a 4.9 one time about a year ago.
When was the last time it was checked?
Last time was about 6 months ago, and it was 5.1.
Okay, so we're at a 5.3, so a
slightly
uptick.
higher.
Yeah.
And I'm thinking the travel might have impacted that. Yeah. And see, this happened right as I was going through some of the weight loss starting to happen. I'm thinking that number is going to continue to fall like a rock. And it's great at 5.3. I'm not complaining.
Yeah. I have anything between 5.3 and under, I'm happy. Once it starts moving to the 5.4 to 5.6, I mean, I tend to say, hey, we need to look at
it's still not diabetes at that point, but it's all right, get that under control before it gets to 6.
Yeah, if you're at your regular physician's office, and this is not meant, I'm a family physician, I still work.
He is a regular doctor, but he's not your everyday regular doctor.
I mean, these consults are a little bit different. They're not on the insurance grid. But what I did before I worked with Jimmy today is I saw a bunch of patients in shorter slides who have insurance products, just regular people, and we're looking at what we can do to help them be healthy, right? So I do both. I play both of those roles. But at a standard doctor's visit, nothing more would have been said about this.
Right.
Your fasting blood glucose is under 100. They probably wouldn't have checked an A1C. Maybe Jimmy asked for it. They got it. It's 5.3. They'd say, you got nothing to worry about. You're fine. Right? So from a standard model, we're really happy.
Even at 5.7, they would have said you're fine.
You're exactly right. Yeah. Now, we did a bunch of other markers. But before we get to them, I want to look at the insulin because we're pretty happy about that.
We're very happy about the insulin because
it was a 7, which is...
And that's the lowest I've ever seen in my life.
Yeah.
that I've tested.
Yeah, and people have different views about this, but to me, the fasting insulin is probably the most important number I look at, because before you develop hyperglycemia, you're insulin resistant. And when you're insulin resistant, you have higher insulin. And I know that there are exceptions to that, but I'll have patients come in with a fasting glucose of 90, they'll have an A1C of 5.2, and they actually have an insulin level of 20 to 25.
So tell me something, Gus. So how can the insulin be so optimally good? Obviously, I want it below 5. I'm getting real greedy now. I want it to be really good. Yeah. And yet have all of that other stuff going on with the inflammatory pathways and the cholesterol and the synthesis. Don't they all contribute to why that insulin might be higher?
Yeah, I mean, it is a holistic system. But insulin's an anabolic hormone. It does have a tendency to respond in periods of infection and inflammation. Insulin might go up. But ultimately, insulin is a nutrient storage hormone, and it's released when you eat, and specifically when you're eating, higher levels of glucose and protein, etc. And so if a person, so the main driver for that is your eating behavior, your frequency of eating. And
I've been keto for a very long time. And it's been as high as 21
so
in a ketogenic state, even moderating protein.
How much weight had you lost before this?
Before the 7 number. So the first week in July, I was probably down maybe 15, 18 pounds.
So if I were to give my best answer, it's the weight loss.
Really?
The loss of visceral fat.
So wouldn't the insulin going down first, then produce the weight loss, or is the weight loss helping the insulin?
Yeah, it's a good question, because we tend to think of the high insulin states as, you can't lose weight because the signaling is so powerful to hold on to fat, hold on to whatever you have stored, glycogen. But that's not totally true. I have some patients who I've worked with pretty severe obesity who had leptin levels over 100, insulin levels 60 or 70. And what we saw as they began to adopt the right type of eating to reverse that, which most of the time, if that's your situation, insulin resistance, leptin resistance, you're going to move more to a low carb, high fat paradigm and use fasting, right? And when we see that, what we see is that they're losing some weight and plateauing, and then losing some weight, plateauing, as we know, as the lipostat works in the hypothalamus. And while they're doing that, the leptin and the insulin are resetting. So those folks are liquidating fat even though they have high insulin. So I'm not sure why. Maybe it's a two-way street with the insulin resistance, that your body is, kind of overriding its signal that you should be holding onto the fat once you're getting into a negative energy balance, and it's like we need fuel, right?
Either way, things are moving in the right direction in that aspect. Yeah,
and I suspect, the triad is inflammation, visceral fat, insulin resistance.
Right.
And everything else is kind of peripheral of that.
And insulin resistance marker on here was really good too.
Yes, exactly.
Unbelievably good.
Yeah, so I think it's that Jimmy was shedding visceral fat. And that was already lowering his insulin. I do not think you have to have normalized insulin to lose weight. In fact, I know you don't have to. Most of my patients can't do it that way. Insulin normalizes as weight normalizes.
And since we ran these numbers, I've done extended fasting. I did a 7-day plus 6-hour fast. I've done regular 20-plus hour intermittent fast pretty much daily. And I've incorporated high-intensity interval training to it. So all that's only going to contribute to this getting better.
Yeah, I can't wait to look at future data, because as we get into Jimmy's plan, it's more than just the lifestyle stuff, although that's the main thing. We've got some cool strategies we're using to really optimize, and we're good. But, for him to have dropped 15 pounds of visceral fat, normalized insulin or lowered insulin, have a good-looking blood glucose and A1C, we're really happy about this. At this time, those are very good indicators.
Yeah, because the HOMA IR, I've never run that. I've done the LPIR on the NMR. Yeah. It's always been bad, like 60, 70. This was 1.6, and the optimal is less than 2.6.
Yes, no indication based on.
So does that mean insulin resistance is healed and or healing?
It means, at this stage, at the moment of this test, it means there's no indication of insulin resistance.
None.
Yeah.
So now what's my problem?
If
it's not insulin resistance, what is it now?
Well, let's take a look.
Okay. See, that's called segue. See, I know how to lead a discussion here. So.
Yeah, so, I don't do all of these other test markers of insulin resistance on every patient, because I think that the insulin, A1C, and glucose are enough.
Right.
But I do think leptin on people who are struggling with weight. But in Jimmy's case, because we like to geek out on data together, we went ahead and did some extra markers. One was called alpha hydroxybutyrate. And
as opposed to beta hydroxybutyrate.
That correct. So alpha hydroxybutyrate can be a very early marker of insulin resistance, and Jimmy's levels were elevated, but it's also an inflammatory marker. So in this,
I don't have any of that, do I?
yeah. So in this particular case, we're putting that in the inflammation bank.
Right.
That's why his alpha hydroxybutyrate went up. His linoleal GPC, which is a very sensitive marker of insulin resistance, optimal, 13.3. His oleic acid, also a very sensitive marker of insulin resistance, optimal at 59. I'm going to circle back around to ferritin.
Yep. And we have a reason for that. We'll talk about that.
Adiponectin, so adiponectin and leptin, I check those on patients who are having either weight issues, metabolic health issues.
Right.
They're both made by your fat cells. They are both involved in energy balance management by your body, so they signal to the hypothalamus issues about where do you stand with your fat mass and what needs to happen. There are genes that underlie whether you tend to have a higher or lower adiponectin level. They're called the adipo-Q genes, and that's part of looking at someone's hunger and satiety genetics.
Right.
People who have low adiponectin will have higher hunger drive.
So mine is double optimal range. Does that mean I'm never hungry?
No, it doesn't mean that. But it's good because that's one positive marker in your favor. So the typical thing we'll see with somebody who's got unhealthy obesity is they're going to have a very high level of leptin and a very low level of adiponectin. And then when you throw high insulin, that's a different type of triad. That's a biochemical triad. And for those individuals, if you don't know that and you just try to go on a diet, you follow whatever diet,
and you're starving.
Yeah, you're
regardless.
You're not going to succeed because you're not going to correct the hormonal imbalances.
My markers aren't that way.
No, yours do not look that way. The adiponectin was excellent. So
leptin was funky monkey.
Yeah, leptin was
on the borderline of elevated.
Well, remember this. So leptin is secreted by your fat cells, right? And so as your fat mass increases, you make more leptin. And leptin's job is to go to the hypothalamus and say, hey, we got enough fat. And then if the hypothalamus says, okay, we have enough fat, we have adequate stored energy on our body, it will maintain a neutral energy balance. It'll tend to not want to gain weight or lose weight. Even if you overeat on a given day, it'll poop out more calories, make you sweat, what have you, and if you undereat for a day or two, it'll use some stored energy, but try to make it up quickly. Now, if somebody has the potential for leptin resistance, and insulin resistance and leptin resistance tend to run together, what will happen is over time they see these higher levels of leptin as their fat mass is increased, and then the brain becomes insensitive to it. There's also some theories about hypothalamic inflammation and potential influencers there, but that's off on a different rabbit hole. But once your leptin starts to rise, the rise in leptin is the indication of potential leptin resistance.
Right.
The hypothalamus has stopped listening to the signal, the same thing that happens with insulin resistance. Right? So then the brain begins to actually think there's not enough leptin, even though leptin's high. Mm-hmm. So it says, hey, we need to see more leptin, right? Because that tells us that everything's hunky-dory with its stored energy. So it's going to engineer the production of more leptin. Well, how does it get more leptin? It makes more fat, right? But your brain can't make fat. All it can do is make you hungry.
Right. So it makes you eat more.
That's right. And so you lower your metabolic rate,
right.
You increase hunger drive until you gain more fat mass, then the leptin rises, the brain sees it and says, hey, good, we're good again. But then it raises again. A lot of different factors influencing it. We don't know them all, but a high insulin state appears to be one of them.
So Gus, I've heard many of people on my podcast over the years talk about insulin resistance and leptin resistance kind of working in tandem. Mm-hmm. What I'm seeing on mine is you're telling me the insulin resistance isn't there.
Right.
But the leptin resistance propensity is there.
That's right.
How is there that discordance?
It's because some people don't have both. There's clearly a strong,
lucky me.
Yeah, there's clearly a strong link between insulin resistance and leptin resistance. But I've got some patients who have leptin resistance who do not have any indication of insulin resistance.
Really?
And I have patients with a lot of insulin resistance who do not have
no
high
leptin resistance.
Yeah, exactly. So in your particular case, it's possible that was an influencer. You did used to have higher insulin levels.
Yes.
Inflammation is one of the influencers of leptin resistance.
That makes sense now.
Yeah, so that could be
back to the inflammation again.
Well, we also know you have a large body mass, right?
And I do have a lot of the middle of my body. So
and so you may just have high leptin and it might not be leptin resistance. I don't know.
And the losing the weight will probably make that normalize.
Yeah, and so of course if a person were to lose weight the wrong way and they have high leptin resistance, the leptin is going to plummet. The brain's going to geek out, and you're going to get real hungry, and then you're going to blame yourself.
If I get hungry, there's something bad wrong.
Yeah.
because I don't get hungry anymore.
Yeah. So at this point, Jimmy's appetite is regulated just fine. So we don't really know exactly where to place the leptin. Does it mean he has leptin resistance or not? We don't know. But it'll be fun to track. But we're very excited to say that he does not have any indication at this time of insulin resistance.
Which is a shocker to me.
Yeah, and not just on the basis of an A1C, glucose, and an insulin level, but also looking at oleic acid and looking at these other markers that are very sensitive. So I'm very, very happy with that.
So let's get to the ferritin, because this is interesting.
Yeah, so the ferritin's pretty high, 307.
And it always has been.
Yeah.
I've always had, we talked about earlier, the cholesterol clearance issues.
Yeah.
I've always had issues with higher iron, and I'm thinking it's a clearance issue.
Well, so obviously one of the first things you think about when you see high ferritin is hemochromatosis.
Right,
Yeah.
and I do not have that.
Yeah.
I've had it tested.
Yeah, it's a very common genetic variant, and there are variable levels of penetrance of it, meaning that you can have the gene and have low level iron storage issues, or you can have high. So even when I see only sort of a low level of extra iron in the system, I'll still sometimes ask them to get a hemochromatosis check, because if they have that gene, we need to know.
Right.
They're going to need to get blood periodically.
And something happened a few years ago. I think I told you this story, where I had the high ferritin and I was recommended to go give blood, and they said give it as often as you can.
Yeah.
So as often as you can was every 6 weeks.
Yeah.
And I got too low.
Yeah. So
And I got in danger. This
Yeah.
is like 4 or 5 years ago.
Yeah, so patients that who have the high ferritin, I do recommend that they consider dumping some of that, and the reason being that ferritin puts an enormous oxidative stress on your organ systems, and so over time there's accumulating damage from a high ferritin level. Some of the people in the longevity community obsess over this number.
Yeah.
I mean, they literally self-phlebotomize.
But you got to be careful with it. You need to be carefully monitored by a doctor. So maybe I'll give once a quarter.
Yeah.
And that's probably enough, would you say?
So what I'll typically do is say, okay, let's say it's 300. I'll say, let's go ahead and have you go donate a pint. And then let's wait about, half a week to a week and recheck the level. Let's see where you
see how far down it goes.
Yeah. And then when we see what that level is, then we gauge when should the next
Okay.
one be. And then over time we figure out that person's optimal schedule.
We will be doing that pronto.
Yeah. Now here's the thing. Jim, if you have a high ferritin and you want to give blood to get rid of it, your blood is good blood. People can use that blood. The medical
they
system
gave me hell about it because
medical system needs your
the higher iron.
Yeah, it needs your blood. But here's the thing: if you're going to the Red Cross to give blood because your doctor told you ought to, they're never going to take your blood, right? And so this is where the
Don't
blood.
tell them.
Yeah, you can't. Yeah, don't.
Although they test it, they know. They're like, have you ever been tested for hemochromatosis?
Yeah.
No, I don't have any idea. What is that?
Yeah, because here's the thing. Otherwise, in some of my patients, what ends up happening is, or let's say that they had a history of hepatitis exposure, so they can never donate blood.
Right.
They have to go to an oncology office or hematology office. They have to give the blood that way. It's expensive, and the blood gets dumped in the trash.
To me, if you have high iron levels, it's the perfect blood to give to an anemic
Exactly.
patient.
I know. Yeah, I know. So, but obviously, a bloodborne disease via transfusion is a serious issue.
Yes.
So that's why they have to be so.
Agreed.
Yeah, I agree with them. But for individuals who are just trying to dump some extra ferritin out of their system because of the long-term potential for damage, they should be able just to go.
I see a business opportunity here for some enterprising entrepreneur.
Yeah. Well, given how much of this I'm seeing in patients these days, I'm seeing a lot of patients with high ferritin. Yeah. And now the reverse would be low iron, and that's a problem too.
That's a huge problem.
Yeah, and many people have low iron. It can take a very long time to rebuild iron stores, and that creates a lot of problems as well.
I've even gotten rid of my cast iron skillets. I have my multi has no iron in it. I just don't put iron. I mean, I still eat meat, and there's iron in the meat, but yeah, it's almost impossible to avoid it.
Well, also remember, ferritin is a marker for oxidation and inflammation. It is an acute phase reactant. Anytime somebody is fighting an acute infection, the body dumps ferritin.
Right.
Yeah, so...
Would it also show up in the oxidized LDL because the ferritin's higher?
I tend to see, so when I see people who have a very high oxidized LDL...
Which I do.
And along with inflammation, I will typically always see a high ferritin as well.
So we're seeing familiarity in all these markers.
Yeah, the big theme is coming back. Now, ferritin is also a marker of insulin resistance, but in this particular case, it's not. Right.
It's not compared to all the rest of them in the green.
Yeah, this falls.
That's like the oddball one.
Yeah, this falls into inflammation oxidation. category, and and then potentially looking at iron sources of iron. The cast iron skillet, that's smart. I had some patients who had
I was sad because I loved cooking everything in the cast iron skillet.
I know, but I had some patients who that turned out to be the issue with their high ferritin.
Wow.
I don't think I've ever seen a case where it's just somebody who eats more iron-rich foods.
Right.
It's either
like cholesterol.
Yeah.
Eating cholesterol doesn't raise your cholesterol.
Right. It's either they have something like hemochromatosis.
Yeah.
Or they're getting something through like iron skillet,
yeah.
or they're dealing with inflammation, oxidation.
Yeah.
Yeah. Now, drinkers, alcohol too. Anybody who's
What?
Yeah. Anybody who drinks a lot of alcohol will begin to have a high ferritin.
Yeah.
Yeah.
I don't touch alcohol.
Yeah.
Except
All right.
on rare occasion.
Yeah. So we've got we're gonna the ferritin falls back in the inflammation box for me at this point.
Yep. Makes sense.
But the insulin resistance markers look great. And then we look at our nutrients, and what we see here is the vitamin B12 was 1,300, that's good. Intracellular folate was at 1,200, that's good. B6 is at 58, which is perfectly fine. Vitamin D was 41.
It's lower than I wanted.
Yeah.
I was away from my supplementation
Yeah.
while we were traveling. One of my supplements here is a vitamin D. I think we brought it. Oh, here. Yeah, so it's a D3. I used to take a D3K2 complex, but they stopped making the one I liked.
Yeah.
I know you wanted me to take one. I think you...
There's one that the that Sona compounding pharmacy
Sona,
has.
right.
It's a good one. That's 5,000 units, and it's the D3K2.
Yeah. And I used to do 10,000 IU.
Yeah.
But I had not been for 2 months while I was traveling.
So that's
probably what made it go down a bit.
Yeah, so I would just have you get back on your regular supplement
I am
protocol.
already, yeah.
I think minimal level of 50, optimal levels of 70 to 90.
Right.
Yeah, and so Jimmy was at a 41.
Wasn't
And
horrible, but...
It wasn't terrible, but
yeah.
definitely that wasn't optimized. Vitamin E levels are good, and you can have too much or too little vitamin E. Remember that vitamin E isn't just alpha tocopherol. They put that in a lot of stuff.
Right.
It's tocotrienols as well, and those are very important. Vitamin E is in your cell membranes, and it is an important antioxidant in the cell. So our nutrient assessment overall looked pretty good, as we suggested. Vitamin D needs to improve a little bit, but he's going to be on a supplement. CoQ10, that's where we were. His CoQ10 levels are excellent, 1.8. And Jimmy had just talked about, if you want to tell him again.
Yeah, I used to take both a statin drug, 2 statin drugs, Lipitor and Crestor, and when I got off of those, we know statins deplete your body of CoQ10.
Right.
So I was taking 400 mcg for a couple of years after I started low carb and came off the statin, but haven't really been on it since. So it's been many years, and yet you say mine is
180. Well, no, 1.81. It's a very high level. It's a good level.
That's incredible.
Yeah.
So why?
Why? Well, the point we just made is CoQ10 does travel with LDL cholesterol.
And if only I had any LDL in my body. So
Yeah.
so if I lower the LDL through all these changes we're going to do, is that going to impact the CoQ10 a little?
Well, potentially. So, as you just alluded to, the cholesterol synthesis pathway, it doesn't just synthesize cholesterol, it also makes other important biocompounds. And one of those is CoQ10. And statins, where they interfere with the synthesis pathway, do interfere with synthesis of CoQ10. That's why we'll see CoQ10 depletion. Coenzyme Q10 is a necessary cofactor in something called your electron transport chain. That is inside the mitochondria, and where the process of oxidative phosphorylation, where you're making energy, is occurring. And that cofactor is a necessary part of exchanging the electrons, right? So if you are deficient, you bog down the energy pathway.
Right.
CoQ10 is also an antioxidant. It also mops up some of the unstable energy that's occurring in the process of generating all that energy in your mitochondria. So it's playing both roles. It's a vitally important biocompound.
So this is also protecting me despite the high cholesterol and the high inflammation. This CoQ10
is helping.
that's so good is helping to mitigate
That's
any
right.
potential problems that could happen.
That's exactly right. Now,
Yeah.
And so my patients on statins, and again, I know that could be a bad word to some, but I do have patients, as we discussed, who probably fall into the correct area of where
Right.
the study suggests statin benefit. And I have them all on CoQ10, and if they let me, I want to check their CoQ10 levels because we want to optimize those
They
levels.
better let you if they care about their health.
Yeah, it's so important.
Why would they not let you, Gus?
Well,
What would be the argument?
Because
No, Doc, you don't know what you're talking about.
this is why, and I do understand it, because the CoQ10 test is not available through the standard labs.
So they have to pay full price.
So they may have to pay for it.
What is
right?
it, $50?
Yeah, it's less than that.
It's not, it's
less
so
than
minuscule.
that. Well, and then they do make the case, well, why not I just take the CoQ10? I'm like, okay. But I do like to know the level.
There's no downside, I suppose.
No, there's no downside.
If they're taking a statin, you know it's going to deplete. So.
You know it's going to deplete. I like to know the level because an optimal CoQ10 level, if you're on a statin, is over 2. And that way, if they're going to be on it, we can reduce their risk of myopathy, fatigue syndrome, cognitive blunting by making sure we optimize that level.
Gotcha.
Yeah, and so a lot of people get there with 100. Some people need more. But Jimmy's levels were excellent. So yeah, remember that an LDL bundle, remember, is not just cholesterol. It's triglycerides, it's other fat soluble vitamins, right? And it's also CoQ10 and other factors like that. So these little bundles are going out to the body, being made in the liver to serve a purpose. Remember that they're delivering fat soluble nutrients, they're delivering important antioxidants, they're delivering cholesterol for repair, and they're delivering triglycerides for fuel. And I listened to a lipidologist recently who is a big fan of keto.
Who's that?
You know, I have to go find.
It's not Tom Dayspring, is it?
No.
He's very.
I'll find it for you.
He's low carb, but he's not keto.
I'll find you before when we wrap up.
Sure.
I'll find his name for you. But he said he believes this mechanism is that the synthesis of ketones is in the same pathway that you're synthesizing ketones. Acetyl CoA, which is the substrate, is also going to be your LDL synthesis pathway, meaning that when you're taking all this acetyl CoA and you're moving it into these pathways, that you're going to end up producing a lot of LDL alongside.
Interesting.
Yeah, it was a really interesting theory, but it was making sense of part of what we're seeing.
All right, this next one's intriguing in light of the ferritin level.
Yeah, you talking about the homocysteine?
No.
Or are you talking about the next page?
No, back up. Iron.
Oh yeah, the iron. Yes.
Blood iron.
Yeah.
Why is it normal?
Yeah, because
optimal.
Yeah, and that's what
and ferritin's high.
Yeah, and that's what we were going to get to, right? Because you're not dealing with an iron excess situation.
Right.
You're dealing with an inflammatory response.
So the ferritin being elevated isn't necessarily an iron issue.
Right.
It's an inflammatory issue that if the inflammation corrects itself along with bloodletting in the meantime,
yes,
you're going to see those things normalize, and the iron that is already normal optimal is going to be good as well.
Yes. Now, I will tell you that most people won't check the iron. I did because he
ran everything on me because he loves me.
That's right. Because you can have a temporary high iron from just having eaten a very iron-rich meal. So serum iron levels aren't your best measurement. Ferritin is your best measurement.
Right.
But in his case, the serum iron is fine.
Is ferritin like kind of the A1C of blood sugar?
Yeah.
It kind of shows it over time, whereas the iron in the blood is more acute to what just happened?
That's right. Exactly. Yeah. So the patients who are drinking too much alcohol, the ferritin is really a reflection of liver issues and inflammation from that. Yeah. Okay, so the serum iron was normal, and then we've already talked about homocysteine.
Yes.
It was a little bit elevated. So when we look at our next page, we're going to go into hormones.
Dun dun dun.
Yeah. And so thyroid function, optimal, TSH 1.5, T4, T4 free, and T3 levels all look good. So
wait a minute, I'm keto. I thought keto was supposed to mess up your thyroid. My thyroid's fine?
Yeah, your thyroid's fine. Some individuals, there's been some proposals that if you stay low carb for too long, that you might see suppression of gonadal hormones.
That's what they say.
Suppression of thyroid hormone. The TSH gets a lot of people get it. It has a negative reputation.
Yeah.
Because people
low number means low function.
People over relied on it perhaps and didn't look in detail.
What's all traditional doctors run is TSH.
But I will tell you, it's still the best gauge of how the central nervous system is interpreting thyroid status.
Yeah.
So no, it's not.
It's a marker, but not the whole picture.
It's not the whole picture. But if you have questions about, like, let's just say, because the free T3 levels can sometimes be a little bit low in somebody who's keto.
Yeah.
So you'll see the slightly low level of T3, but then you see the T4 looks good, and the TSH could be optimal.
Right.
More than likely, the thyroid status for that person is fine.
Did you run antibodies? I don't see that on here.
I did not run your antibodies.
Would that be something that I know that usually is indication of, like Christine has Hashimoto's. Yeah. That's how we figured it out, was the antibodies.
Yeah, so I typically will only run antibodies in somebody who...
As a follow-up to bad numbers here.
Bad numbers, or if we see, or if this person has an autoimmune presentation. Right. So if the person's coming in for gut issues and fatigue, and I'm thinking
there's
autoimmunity,
something going on. Yeah.
I'm going to start looking at antibodies.
Of course.
In your case, it was optimal. I don't see any reason to check
No sense
antibodies.
in doing a shotgun approach if it doesn't have any, if there's not a duck around.
Yeah, I don't see any reason to. Yeah, and before this, you told me, despite the stress and other factors that have influenced you, you feel good.
Feel great.
Yeah. So I didn't see a reason to check antibodies.
Yeah.
But for people who are concerned about thyroid function and who have autoimmune conditions, or autoimmune concerns, especially gut, you should ask for the thyroid antibodies as part of your profile. All right, but thyroid function looks optimal. Hormonal function, this looks great. Estradiol, progesterone, testosterone, free testosterone, all fall into.
Can I tell you the testosterone? It's been 300 to 400.
Yeah.
What is it now, Gus?
It's 673.
673! Yes!
Yeah. So his overall gonadal production looks good. Now, the world of health optimization, enhancement, longevity would look at testosterone optimization, and they would say, hey, free testosterone, because that's your bioactive testosterone, of anywhere from, some would say 12, some would say 14, some would say up to 28 to 30. And that's, so you could make a case that this could be further improved for overall health optimization,
I'm sure it will.
And deceleration of aging and body composition. But the main point is that from a reference range standpoint, it falls well into the normal range, and it's at double of what it used to be.
Over double,
right? Yeah. And so people tend to look at testosterone and look at it through a narrow lens. They'll say, oh, okay, I either have low testosterone or I don't. Testosterone reproductive signaling, anabolic signaling is an important function of the body. If it's been downregulated, you have to ask the question why. It can be aging. As we age, we'll have a downregulation of anabolic.
I'm going to fight that hard as I get older.
Reproductive function, but insulin resistance, inflammation, stress, circadian rhythm disruption, all of those factors will influence it as well.
My circadian rhythm's really strong.
So
that's probably contributing to
the
numbers being really good.
But what we see right now is that the gonadal function looks excellent, thyroid function looks excellent. So the body is not showing us from a hormonal perspective alarm signals. Right? It's not, I had one patient, he was actually quite fit. He came in, he wanted to get more information. He had been doing intensive workouts. He had lost 14 pounds of visceral fat. And when we looked at his assessment, gonadal function was downregulated, thyroid function was borderline low, he had nutrient deficiencies. It was clear in his case he had pushed himself too hard. Yeah. So it doesn't matter. You can't look at a person's size and say, okay, this person has...
They're automatically...
No, you really have to... And then you have to see it holistically as one, it's a very important function of the body, and if it's downregulated, there's a reason for it. But in Jimmy's case, we're really excited about the data we're seeing here.
Yeah.
And we expect it to improve further as he continues
It'll
to
have to improve,
yeah. Now, when we looked at the blood count, we do see that the hemoglobin was slightly concentrated and the hematocrit was... Oh, actually, I skipped. I'm sorry. Growth hormone. I forgot to mention that.
Don't miss another good part of my panel, Gus.
Yeah, I apologize. So we also look at DHEA. It's an adrenal hormone and a weak androgen. His levels look great, 150. That's a good level at his age. Human sex hormone binding globulin, you need to look at that if you look at testosterone, because it's secreted by the liver to mop up extra androgens such as estradiol or testosterone. His levels are 69. They're technically in the normal range. They're on the higher half of the normal range, which is why the free testosterone might be slightly lower. And there can be different reasons for it. At this point, we don't see a problem here. We expect it to continue to improve. Growth hormone, you can use the growth hormone or insulin-like growth factor to look at that response. It's 0.3. It's technically in the normal range, but it's on the low side of the normal range.
Sure.
I don't use growth hormone. I use it primarily as a way of saying, okay, is this person, if I see it completely suppressed, really, really low,
right?
Then I'm looking at deep sleep, and I'm looking at, are they getting any form of strength training? I'm looking at some of these other factors.
So one of the things that you have me on, I definitely want to address before we leave today, is the peptides.
That's right.
And one of the peptides, I was talking to my Keto Hacking MD podcast co-host, Dr. John Lemansky, and he was looking at the peptides, and he has some questions about some of them for you. But one of the things that he said, I think it was the 1295.
Yeah, CJC 1295.
CJC 1295 helps with this growth hormone boosting. Right. And then I'm also doing periods of fasting, which helps with the growth hormone boosting. Right. So I'm doing things proactive to make that better.
Yeah, and so in Jimmy's case, I wouldn't necessarily, I don't put people on growth hormone, and I don't recommend growth hormone. Well, you know what, let's do it, and then we'll talk about peptides.
Please.
Is that cool
if
we do that? Yeah. So, but the growth hormone is slightly lower, but you have to have a context. I mean, like, that's just a spot check, who knows? It's just a way of assessing where does someone fall in the range. And most of the time what I'm looking for is undetectable, because a lot of patients will be undetectable.
And it's still pretty close to that.
Yeah, it's still pretty low. All right, then we move into blood counts. And this is part of why, with the iron normal and the high ferritin in that puzzle, why I want Jimmy to donate blood. Because what we see is that his hemoglobin and hematocrit, the two markers for like red blood cell mass, they're both a little bit high. Not terribly high, but a little bit high. his white blood cell count is normal, his differential is normal, and his platelets are normal, meaning the rest of the bone marrow signaling looks normal. Now, you can have a high red blood cell count for a number of different reasons. One could be you have sleep apnea, and it's not being treated. So
I don't.
Yeah, so if you're
I know of.
Yeah, so if you're under breathing all
Christine
night,
thinks I do because she thinks I snore sometimes.
Well, since you've lost the 25 or so pounds, the snoring is a lot better. You've been sleeping over in the man cave because our bed
it's more
is
comfortable.
uncomfortable. So
Yeah.
I don't know what you've been doing. But he used to, as of a month ago, he was snoring really bad.
Yeah. So this is important.
Thanks, honey.
Yeah, just
Sorry.
but just real quickly as an aside for obstructive sleep apnea, a lot of people have it. There are different factors that influence it. It can truly be obstruction to airway flow, like your nasal passages are occluded and you have big tonsils and a big neck and you really can't move air. And those folks will probably need some type of positive pressure device, a CPAP, to effectively move air. And it's important that they do that because if your body is desaturating oxygen, losing oxygen all night long, you're basically going into a stress response all night long. Your body literally feels like it's
Under oxygenated.
Yeah, you are not going to get restorative sleep. Not only are you not going to get restorative sleep, you're going to be in a perpetual stress response.
Yeah.
That is not good. Now, there are a lot of my patients who have sleep apnea, and they're a little bit overweight. Maybe they have some nasal airway obstruction, but they also are just bad breathers. They're breathing through their mouth and into their chest all the time. They're basically hyperventilating, blowing off carbon dioxide, which resets the threshold for apnea in the brain due to carbon dioxide retention. And those individuals, they drop 25 pounds like we were just talking about. If they have nasal issues, they get those open and they begin to practice proper breathing, nose, diaphragm. And they stop being a mouth breather and they correct their sleep apnea. There is a form of sleep apnea called central, and that's where your centers deep down in your brain don't send the right drive, the right respiratory drive. And in those cases, that's a real problem, obviously. Now, typically that's due to either brain damage or 2, medications that suppress respiratory drive, or 3, you're a bad mouth breather and you blow off too much carbon dioxide, and therefore you at certain points your body inhibits respiratory drive. Yeah. So one of the things we'd ask is that question too. If a person has a high hemoglobin hematocrit, are they a smoker? Right? Smokers will put a certain amount of carbon monoxide into their system.
I don't smoke.
Yeah, and that binds up that actually renders the hemoglobin it's bound to ineffective, and so your body makes more red blood cells.
Except for ribs. I do smoke ribs.
Yeah, and then 3 are people like performance athletes. Performance athletes are people who live at altitude. Their body increases red blood cell production to account for that. There are some bone marrow conditions that can cause it, but I don't think Jimmy has those. I'm not that concerned. At this point, I feel like that the red blood cell mass and the ferritin, that I'm still placing them in the same category we've been talking about, and the main solution to that is to continue the holistic plan we're going to be outlining, and the plan he's already been following before my consult. And in addition to donate some blood, let's just reduce that mass.
That's happening when we return next week. So yes.
Yeah, and then once he does it, a week out, we recheck the blood counts, we recheck the ferritin, and then we figure out, does this need to be once a quarter, once every other month, something like that. Yeah, but otherwise the bone marrow looked good.
Great.
Yeah. On our next page, we have a standard what we call complete metabolic
CBC,
profile.
yeah.
Yep. And so the electrolytes, kidney function, protein stores, albumin and globulin ratios, as well as bilirubin and liver markers all look.
Most doctors run these CBCs and CMPs, and that also good, and they don't really ever dig into that.
Yeah, that's right.
Is it just because nothing jumps off the page?
That's right. Yeah, you're not going to do the micro interpretations if everything looks good. I'm always going to look at an albumin globulin ratio, and I am going to look carefully at the alkaline phosphatase and bilirubin, wondering about people's biliary pathways.
And that indicates what?
Well, if you look at the biliary system, it's a detoxification system. It's also how we dump cholesterol, right? So the biliary system is a really important system, and it's where we conjugate and excrete, and the bowel stores it. A lot of individuals, based on inflammation, standard American diet, energy excess, fatty liver, will actually be influencing that system. And as they influence that system, they begin to retain bilirubin in their system, even in small amounts. Alkaline phosphatase will go up a little bit because that can indicate some obstruction in the biliary system. And in those cases, we really need to improve that liver function process, that biliary process, because if you're not, if that system isn't working properly, you're not detoxifying. And that means you're retaining a lot of stuff in your bloodstream, and that's not going to be good for you. Yeah.
Right.
Also, out people drinking a lot of alcohol, we'll start to see bumps in that. But this all looks
drink
really
alcohol.
good. Yeah. But yeah, or keep it in moderation, right? Yeah, but that looks really good. I'm happy with that. Magnesium levels 1.9.
A little low.
Yeah, calcium is part of a CMP. You can't measure calcium through a serum calcium. You could if there's a serious problem,
Right.
and then so it's appropriate to check. Then you could see a low calcium or a high calcium, and that has a medical workup that you do for it.
Right.
But if you were really trying to assess your calcium status, you'd have to look at things like parathyroid hormone,
Right.
which is beyond the scope of what we're doing. Most people aren't calcium deficient. But calcium was fine. Iron was fine. The magnesium is 1.9, technically normal. I like magnesium levels to be 2.2, 2.3, 2.4.
Almost there.
Yeah. So
Higher dosage in my supplements would help.
Yeah, so most of my patients I'll have on some form of either a micronutrient supplement, mineral repletion supplement, or straight up magnesium powder. Those who are dealing with stress, mood, or sleep issues, I'll try to have them on magnesium glycinate if I can.
Right.
Because of,
And I know if you take magnesium about an hour glycinate before you go to bed, it can actually help with your sleep.
Absolutely.
But my sleep's good, so
yeah,
it's
yeah.
like
So it's really not a problem.
No.
Yeah, but there are some physicians out there that basically feel that everybody's probably magnesium deficient. I do think
it's probably true.
and it probably is true.
For a lot of people.
I think most people who aren't being proactive about mineral intake are in fact mineral depleted, and especially people staying in a ketogenic state. Sodium status is so important for them.
Which is why we all take Redmond's real salt now.
Yeah. There are genetics for who has salt sensitivity, and therefore
So small.
Yeah, and it's a very small
Right.
percent. Yeah, and if you have those genetics, then high sodium can definitely influence.
Probably
blood
know
pressure.
it if you have that.
That's right. But if you don't have that, sodium is good for you, and you probably need it. Now, I prefer natural forms of salt, not
Yes.
modern manufactured.
Have you
salt.
had the Redmond's
I have
real
not
salt?
tried it.
Oh, I should have brought him some.
I would have loved to have had it. You can show what you did bring me.
Yes, I brought him some of our chicken
wait.
eggs.
I can't wait to
See,
get
I
into
know how
it.
to suck up to my doctor.
Yes, pasture eggs. You got me. Yeah.
That's your love language.
Yeah, but so for mineral repletion, I like the trace mineral solutions because they're not just sodium and potassium.
Right.
They actually have the 70 plus trace minerals
Right.
that are present, that used to be present in our foods.
Right, not anymore.
Yeah,
Been
and
stripped.
so I'll use that. Some people will grind up eggshells and things like that.
Right.
And include them in their diet.
We have a few eggshells we could grind up.
Yeah, bone meal can also be used, right,
Uh-huh.
as a way of getting some of those important minerals and
Yep.
mixing it. But so our big picture, what we see here,
Yep.
right, is that he's always had elevated cholesterol, and he appears to be a hypersynthesizer, hyperabsorber. So his body is designed, his biological design was to have higher levels of cholesterol. That's not a disease. At some point in the ancestry of the Moore clan, tracing it back, there was an advantage to having higher levels of cholesterol, as well as this LP(a) protein that he has.
It's a longevity indicator from the people I've talked to,
Yeah.
that in the tribes, you would be the one that if everybody else died off during the starvation period, you would be the one that would last the longest, the
Yeah.
highest with LP(a).
That probably could be the case. I'm not sure, but I know that it's there for a reason, right? It's not that it was a mutation
Right.
that rendered a person non-viable.
Right.
It would have worked itself out of our population.
Am I non-viable?
Yeah, but we like his triglycerides, so we're really happy about that. We see clearly diffuse markers of inflammation, homocysteine, CRP, intraarterial markers of inflammation, a high oxidized LDL level, so markers of oxidation, and then we do see this hyperabsorption and hypersynthesis. Clear omega-3 deficiency, vitamin D is not optimized, so possibly impaired methylation processes, and then the high ferritin, which is also inflammation, oxidation.
But no insulin resistance.
Yes, but his glucose,
High inflammation, but no insulin resistance. I hope you're getting this, guys.
Yeah. So his metabolic systems, though, we're looking good. We do possibly have some minor leptin resistance. We're not sure. Maybe not. It might just be due to the higher fat mass that he's had. But adiponectin looks good. Very sensitive markers of insulin resistance like LGPC and oleic acid look very good. And his insulin, A1C, and glucose all look good. So we're really happy with that. Overall nutrients look good because he's paid attention to these things other than omega-3s.
Oops.
Yeah. And then hormonal signaling looks really good. Adrenal hormone signaling, thyroid hormonal signaling, reproductive hormonal signaling all look really good. So we're happy with that. Is gonadal signaling optimized? Nah. Get the testosterone up to 900, the free testosterone up to 15, 16.
It will get there, I promise you.
Then that's optimized. Growth hormone slightly low, but we don't want to overinterpret that. The basic stuff, but blood counts, metabolic profile, all looking good. The big picture theme for Jimmy is inflammation.
Dun, dun, dun.
Yeah. And so what are the sources of inflammation? Well, we know dietary, right? I mean, for some individuals, it's oxidized oils, industrialized oils, high sugar diet, processed carbs, refined sugars, people who are sensitive to different components of plants, whether it be grains, legumes, and different types of even non-starchy vegetables. Some individuals are very sensitive to the oxalates, or they're sensitive to some of the other noxious compounds in those plants.
Right.
Not everybody is, so that's not an anti-plant rant. I'm still.
He's very pro-plant, I promise you.
Yeah, I'm very pro-plant. But, so foods, and then, of course, tobacco, lifestyle elements, excessive alcohol. Jimmy doesn't have those aspects. Overdoing it, right? Some individuals may have a tendency to hyperproduce all the time. I don't know if there's any of those in this room.
What does that mean, hyperproduce?
Always on, always producing, always, yes.
Am I always on, guys?
Yeah, and so
But I'm about to be always off for about 6 months.
So I don't think there's anybody in this room who qualifies as that, right? No.
Who's she talking about?
Yeah. So stress. Jimmy and Christine have worked really hard for a long time. I've gotten to know them, and I've been able to observe their work, and obviously have been producing an enormous amount of content for a long time. A lot of research. They do it because they care, and they're out there in the public arena, so which means there's a lot of people who like to throw stones at you as well. It's great that we have debates about these best what's the best way of eating for an individual. I think all those debates will continue, and we're all going to have elements where we were right, and there are going to be places where we were wrong, and we weren't quite on target, and that'll get corrected. But the debate should be congenial. We're all trying to advance. Now, unless it's the representatives from the pharmaceutical company who have a clear agenda.
We're going to go after them.
Yeah, but for the most part, the rest of the science community that's not being funded by pharmaceutical entities, they're just trying to elucidate truth and get the truth out there. And we have conflicting opinions about that.
Yeah.
And time will tell. But that's when you're looking at population health and mechanisms. But once you have individual data, you know truth for you.
Yeah.
Right? And that's where we can begin to pick a plan that we think is going to address the aspects we see on Jimmy's data. And then we get to follow the data and know that if we pick the right plan or not. And if carnivore keto were to result in loss of visceral fat, reversal of insulin resistance, optimized hormonal function, and with the right focus we're going to talk about, get all the key nutrients into his system, then the truth for Jimmy is that carnivore keto is a good eating plan.
Along with de-stressing.
Yes.
That's the confounding variable in this, because I've been keto carnivore since January. Lost a little bit of weight at the beginning, but it kind of stabilized. I think the key element here is the stress reduction.
I agree.
And so it's almost at this point, anything with the stress reductions kind of result in positive movement in those numbers.
I agree 100% with you. Stress is a major confounder.
But I do like keto carnivore, so that makes it sustainable for me.
Yeah, so that's a major confounder. We definitely know that correcting the omega-3 status could make a major difference.
And we're doing that.
Yeah, and
I'm on the Pro Omega 369 now.
And as he continues to lose this visceral fat, we expect to see further improvement in these numbers.
And the increase in muscle mass is probably going to have that effect as well. It would have to. As long as I don't overtrain.
That's exactly
That's on Trent, so don't let Trent overtrain me.
Trent will definitely push, and we had Trent had those conversations about him. So what I'd like to do is, one, recognize we're not recommending any pharmaceuticals at this moment. He
would have said no anyway, by the way.
Yeah, that's right. But had he had the super high level of plant sterols, I'd be like, well, Jimmy, you might have acetylsterolemia, and you might benefit from a sterol inhibitor in your gut, right? I mean, that would make sense. But we're not recommending any. Had he not done it, I would be recommending a coronary calcium score. I'd want to know, are we a plaque former? Are we dealing with that situation? He's already done it. The scores have all looked good. So that's not our primary focus right now. So then we would move in, we're not using a pharmaceutical tool. Sometimes they're the right tool for the job. We'd move into, what are our supplement tools that we're using? And we've got a pretty good collection here. Obviously omega-3s, obviously vitamin D. And based on his prior methylation genetic review and his homocysteine, we are going to add a methylation complex that has the vitamin B6, the vitamin B12, well, the methyl B12, methylfolate, methyl B6, and also riboflavin. You want to make sure you optimize riboflavin.
Orthomolecular products.
Yeah.
Methyl
So-
B complex.
Yeah, so a comprehensive methylation supplement will be more than just methylfolate and methyl B12. It'll include riboflavin. It'll also often include betaine as an option. So there's just different ingredients that can.
There's all kind of B vitamins in this thing.
Yeah. So we want to improve that, which I think will lower homocysteine and also probably help his body perform better, maybe some of the detoxification issues. And then we've got, I like this one. This is one I take myself because I just can't get accustomed to organ meats. I really want to.
I'm going to try frozen liver. There's so
Yeah.
many people on Twitter that
Yeah.
call themselves the frozen liver gang.
Yeah.
I want to eat frozen liver. I'm going
Yeah.
to try it.
I've
But
been-
this is good in the meantime.
I fully believe that the nutrient concentrations in organ meats are something that human blood bodies are designed.
Rather than the freeze dried, but
Yeah.
this is good
well,
proxy.
I think that this is good proxy, and I might never get any past this, right? But,
All right, my job is to get Gus on camera to do some frozen liver with me.
yeah.
If I'm successful at reversing
Yeah.
my numbers, he's got to promise to do that on camera. So
Yeah, yeah, but I think that there's
it's not promising. You noticed that, right?
Yeah, from the study, all the study of evolutionary biology, however you want to look at that, and all the study of human performance, I have no doubt that human beings were designed to thrive when we have access to animal products in our diet, but the whole animal, not the
Muscle meats alone.
Yeah, lean muscle meats. One of my favorite carnivore guys right now, Paul Saladino.
I've heard of him.
Yeah, he's good.
I've interviewed him on Living the Beef.
Have you?
Yeah.
Ah, okay. I didn't.
Oh yeah, dude. If they're in this space, I've talked to them. I promise you.
Yeah. So Jimmy knows him, and I really feel like he's on point with the right approach. Do you agree that?
I do. I think I love Sean Baker and I
Mm-hmm.
love what he's doing, but 2 ribeyes a day. I
Yeah.
mean, where are you getting a lot of the micronutrients? So I do think Paul's onto something. He encourages liver. He encourages salmon roe, which is caviar, and some of the other things.
He calls it a nose to tail.
Yes.
You're eating the whole animal.
Yes.
So chew on the bones, eating the tendons, getting all the glycine and collagen protein.
Yes, and bone broth.
Yeah, he points out, and I think very accurately points out that if you're just eating the meat, the actual muscle meat,
Right.
then you're looking at methionine, glycine, and, ratio issues.
He's working on a book, by the way.
Yeah, he needs to write one.
Oh, it's coming out later this year.
Yeah, he needs to summarize that. And then when you look at, of course, all the nutrient needs, an animal actually has every single one of these minerals and every
Right.
single one of these nutrients in them, and it makes sense that we could get it all from an animal product.
We did a podcast on like what's in a ribeye, and it's a lot of micronutrients people don't even think about.
Yeah,
Yeah.
it is. Yeah.
Yeah, well, they also don't measure, right? Like they're not going to measure the vitamin C amount in a piece of animal meat.
But it's not a blob of protein, which is what
Yeah.
mainstream would have you
That's
believe.
what they'd have you believe. Now, obviously, with carnivore diet, you've got to, the actual proper carnivore diet is not just a ton of protein. You're still
No.
your protein is.
I keep my protein still moderated.
Yeah,
it's higher than traditional keto. I will
Yes.
tell you that. I'm able to get maybe 130 to 140 grams of protein, still keeping the fat around 75%. No carbs, obviously. Whereas on keto, my total grams of protein were probably 80 to 100
Yeah.
grams because
Yeah.
you had to kind of, with the carbs, it still became a calorie issue, a hormonal response issue.
That's right. Yeah, and it's the same thing. So if you overconsume protein, then ultimately there is a potential you're going to convert it to glucose. Plus, there's just other aspects of high protein diets that can be challenging to our physiology. We don't think from an ancestral standpoint we would have been able to maintain that level of protein intake daily.
Yeah.
So that's what our systems. But the fat, definitely, we would have been hunting that fat.
That's what they would have ate first.
Oh yeah.
Right for the brain.
The brain, the liver, and the fat.
Yes, they loved all that.
Yeah.
And they threw away like the lean meats. It's like we can't. That make me hungry. No. So-
Yeah, exactly. Yeah. So, I'm not I don't follow the carnivore diet myself.
You do not.
Yeah.
You do kind of an opposite. You're almost like my Keto Talk co-host. You're almost ketotarian.
Yeah.
Which you're keto with more of a plant-based focus.
Yeah, I am. I see some of the wisdom in that some of these noxious compounds in plants could be a trigger for a lot of people.
Oxalates, especially
Yeah.
Sally Norton talking about those.
Yeah, and many of the things we've called phytonutrients that might actually be more just phytotoxins, and that we what Saladino argues is that we can get the hormetic response through sauna, through cold, through exercise, that we don't necessarily...
I do all those things.
Yeah, so we don't have to necessarily use plant toxins as a way of stressing our system and creating hormetic responses. But when you go and do a thorough study of anthropology and look at human civilizations, we don't find good examples of people who never ate plants, right? Like even... whatchamacallit, Inuit, I guess, right?
Inuit.
They in the summertime,
seal blubber.
Yeah, in the summertime, they gathered and ate as much of the plant material as they could find up there and put it into their system.
Which was still minimal.
Yeah, which was still minimal.
Compared to the animals.
Yeah, so, what I find, and I think you'll agree with, is that, people who go vegan and say, look how much healthier I am because I went vegan.
They got rid of the crap.
Yeah, exactly. People who go paleo, people who go keto, if they do proper keto, people who go carnivore, if they do it properly. Every time you switch from a standard American or industrialized diet to one of these diets and improve your food sourcing, you're going to lose weight and get
The
healthier.
removal of the bad is the key.
Yeah, and the worst of the bad are processed, refined, added sugars and industrialized oils and additives and all of that, right? That's the worst of the bad. Then we can get into a debate about saturated fat versus plant lectins versus protein, right? Now we're on a whole
fiber, no fiber.
Yeah, exactly. And so I think that debate will continue on. I think it's great that there's voices for all sides who are really looking at it.
And it could be they're all right. It could be that for certain people, based on their genetic profile and their blood work, find that they do better with less plants, and then some do better with more.
And I've shared this with you. My genetic analysis shows that I'm better with low protein, and I have determined through my glucose testing that if I eat a high protein meal, that will spike my blood sugar more. It'll go up.
Mine does too.
More than eating carbohydrates or legumes, which I don't eat a lot of carbohydrate, but I can eat some carbohydrate and check. And I've been testing this, and my blood sugar may go to 110 postprandial, and then I can eat a bunch of protein, eat a bunch of sushi, like sashimi, and my sugar, if I eat more than I need, it'll go up to like 130. So I do tend to convert protein very quickly, and then my saturated fat tolerance is low, and if I overconsume saturated fat, I will end up bumping my lipids and also bumping inflammation.
So you use a lot of monounsaturated.
So I'm a monounsaturated fat fan, and Paul Saladino.
Because you know that about yourself.
Yeah, is not as much of a fan of that, right? He thinks all of his avocados, all of them, right? I mean, he's a pure carnivore. So again, I think for each one of us, there's some truth probably to all of these dietary programs, and all of them have positive benefits. But when you get your own data and you begin to understand yourself and pay attention, right, what your best diet is.
Which is why you created this personalized healthcare. You wanted it to zoom in specifically on individuals. So today, it's Jimmy Moore, and you're giving your analysis based on what you've seen.
Yeah, and so for Jimmy, with the carnivore keto diet, he's lost weight, he's reversed insulin resistance. We don't...
That last one's the big one.
Yeah.
Because that's been my bugaboo forever.
That's a huge one.
Is the IR.
Yeah.
And I've always identified as insulin resistant. I can't do that anymore.
Yeah, he is not insulin
I won't
resistant.
do that anymore.
Yeah.
It's just I'm still managing an inflammation overload.
Yeah.
That's now the new
That's your new
inflammation
situation.
or insulin resistance.
Yeah, so that insulin resistant reversal is a major deal. It's a major deal.
But it makes sense. You would think that would happen with keto.
You would. Absolutely.
Should.
Yeah, it should if you're doing it properly and paying attention to food sourcing and stress, right?
Right.
Now, his particle distributions apparently are better than they used to be, based on the fact that you said that LDL particle count was 3,700 before.
It
right?
has been.
Yeah, but so what we see is that at this point we don't know. Is inflammation lower than it was? Right? Is it higher than it was?
Can't be much higher than it was.
Yeah, exactly.
It's pretty high.
So we don't know. So we'll look forward to, at an appropriate interval, retesting this and seeing where we stand. But for Jimmy, who knows diets very well, knows more about it than I do, I would say stick with a keto carnivore plan for now because of what the accomplishment you've had. But
with the better nutrient density.
That's right.
I'm working on it. I'm buying some liver.
Yeah.
I'm getting some salmon roe. We're going to add these things in.
Yeah, I want him to, organ meats and omega-3s and, making sure that he's getting those more nutrient-dense portions of that animal product. So following that type of carnivore keto diet. But I wouldn't take him off that right now. I would continue that diet and see where we get to and correct these other issues. And
I'm comfortable with it.
Yeah.
It lets me eat one meal. It lets me fast for 20 plus hours. Pretty easy.
Yeah, that makes sense too. It really does make sense when you eat that type of food. And
Yeah,
fat
everything
intake.
calms down in the body.
Yeah.
I mean, that insulin coming down, I think that is a huge indication of, okay, something good, positive is happening.
Absolutely.
My goal is well under 5, by the way. I want to see 3 or 4 next time I see you.
Which would be great. And do you have a goal for your weight right now where you'd like to get to?
I've done the weight loss thing. I don't care. I just want to be healthy and strong.
I agree with that.
Because if I put a goal of, okay, X amount of weight, what if I gain 30 pounds of muscle?
Yeah, I'm with you on that.
Which I'm going to try.
Yeah.
So
I really like the disassociation from the weight at this point, because that's not really our focus. Our focus is health. Optimizing health. With optimized health, your body will optimize weight. And for some people, you'll be heavier, and some people, you'll be leaner, and that's okay. So I really like the fact that this is no longer a pursuit of weight loss. Like in the very first days when you talked about, how you started this. This is just a pursuit of ultimate, of the best possible vitality.
I don't want to fall into the pattern of my dad had a heart attack at 48, 50, and quintuple heart bypass at 54. Yeah. Both grandfathers died in their early 50s of heart-related issues, and my brother had 3 heart attacks at the age of 32 and died at 41.
Yeah.
I got major genetics that say I'm supposed to have a heart attack soon.
Yeah. Well,
that ain't happening.
That's not. Well, I agree that it's not likely to happen anytime soon, and let's try to make sure it never happens.
Well,
right?
That's why we're here.
Yeah.
That's why I'm going away for 6 months.
Now, speaking of the stress, we are using some supplementation perhaps to help with that, right? I don't know if you wanted to.
Please go.
So what we did is I did a test on Jimmy. We looked at his salivary adrenal function, and we also looked at neurotransmitter balance. I will tell you that right now, if you go and look up urinary neurotransmitters, you'll see a lot of controversy about it. So
it's adaptocin, Prolint, and Lintra, because it's backwards on that.
So there's a lot of scams out there with urinary neurotransmitters. Companies that'll give you a urinary neurotransmitter report, tell you have low serotonin, low dopamine, all this stuff. They'll put you on supplements, and then they'll retest you. And one company was even found to be fudging the follow-up data. Oh, look, you're better, right? Don't you feel better? Now, the central nervous system, is a delicate balance of many different neurotransmitters, hormones, etc. And we know about the balance of excitatory and inhibitory neurotransmitters. Most people in our time, because of our stress exposures, our technology, our circadian rhythm disruption, everything that we're going through, will have depletion of inhibitory neurotransmitters like serotonin and GABA, specifically GABA more than anything else, which will influence sympathetic and parasympathetic balance, and people become hypersympathetic most of the time. They get used to it, so they can't tell. They don't feel fight or flight. They don't walk around going, I'm all jumpy and crazy. Some do, but a lot don't. They just have normalized it. And you can use this type of assay to get a sense of that neurotransmitter balance. And then you can look at that cortisol curve over 24 hours. Adrenal glands are messengers. They're just doing what they're told. It's the central nervous system that's sending that signal. So we identified that there were some potential neurotransmitter balances for Jimmy affecting that cortisol response curve. And so we're using a supplement protocol where we use natural compounds that are substrate and cofactor for the synthesis of neurotransmitters. And these formulas vary depending on what neurotransmitter you're trying to rebalance. Lintra is a GABA formula. So it has GABA agonists, because there's a debate over whether GABA, gamma-aminobutyric acid, crosses the blood-brain barrier or not. It may, but we don't know. But you can use GABA agonists, and then you put it together with some magnesium and theanine and something called lactium, and over time that will improve GABA synthesis in the brain, so it can help with the GABA balance. And then the Prolin is one for serotonin. It has 5-hydroxytryptophan, and they have glycine and vitamin B6 in it.
And it doesn't make you sleepy. Don't let tryptophan throw you off.
That's right. It does not. 5-hydroxytryptophan you need to make serotonin, which you need to make melatonin. And then we have one for adrenal support based on the adrenal curve we saw. You've been taking these for how long now?
It's been several months now.
Yeah. So usually I'll use about a 3-month protocol to try and rebalance neurotransmitters. I'm not telling you it's always successful, but the data from the company I've been using, Senesco, they have over 100,000 case studies. They just presented their data at Wake Forest University to a team of neuroscientists. The data is very good. If you give your body the right opportunity to rebalance neurotransmitters through nutrient-based supplementation plus lifestyle changes Jimmy is doing, you can see that rebalancing occur. You could measure heart rate variability
And I do.
Yeah, and then there
I
are.
have a chest thing.
Yeah,
Over 7.
Do you have an app that breaks it into high frequency, low frequency?
No.
Yeah. So there are apps that will further divide heart rate variability into high frequency, low frequency.
I also wear the Oura Ring.
Yeah, me too. I've got mine on.
But it doesn't do the low either.
It doesn't. So high frequency is parasympathetic and low frequency is sympathetic. And so if you can get that reading, you can actually see where you balance. I used an app that could help me with that. This was several years ago when I identified some my innards weren't doing well, despite the fact that I felt good and I was positive and I was taking the bull by the horns in life and very attentive to my lifestyle. And I said, there's got to be something I'm not accounting for, and,
right.
And it was stress.
I've heard that somewhere before.
Yeah. So I used the heart rate.
Was your inflammation high?
Yeah, I did. It was. So I used the heart rate variability, and what I found was I run, I work. I mean, I'm not a super fitness guy, but I tend to stay physically healthy. So my heart rate variability, based on how they scaled it, could sometimes be in the 90s,
which is really good.
With a resting heart rate in the 50s.
Really, really good.
But guess what? When you looked at the different frequencies of low and high,
I
was still sympathetic dominant, right? And I tried everything, various forms of meditation, breath work, I pray. I mean everything I could to hack my parasympathetic nervous system. And guess what? It didn't change.
So how did you fix it?
I started taking more time off.
Somebody should do that. I'm not saying who, but maybe for 6 months, go away.
Yeah, exactly. I literally had to just say, this is unsustainable. I can't constantly push trying to build a medical clinic, trying to change the system, trying to do everything, writing a book. I am going to have to be done by a certain time of the day.
So is that what in the day-to-day, you make this conscious decision to keep that benefit going? Yeah.
At that time, it was a major change. I scheduled myself off at 3 o'clock every day.
Wow.
And I left, and you couldn't find me. And
ABC,
and most days of the week, until my kids would get home from school and sports around 4:30 or 5, I would just go into the woods with my dog, no phone. And
nature walks.
Yep. I'd spend about an hour and a half by myself with my dog walking through the woods.
I am so doing that when I'm off, by the way.
Yeah. I would not allow myself to run, and I had to just stop and contemplate, and it took about 3 months of that.
Wow.
But about 3 months in, I felt it happen. I literally felt like it was
everything unravel.
Maybe we need to stay in Black Mountain for 3 months rather than just 2 months with all the walking trails.
Yeah, we are planning on staying in our home in Black Mountain, North Carolina.
Yeah, which is great.
For 2 months.
We'll be closer. It'll be easier to get our blood work and stuff. But when I felt it, it was like the sound of a furnace going off, and you didn't know it was running. It just kind of, all of a sudden the sound disappears. You're like, whoa, something was running. And it was like a motor inside me that I think it probably started about the time I was working my way to med school that had never turned off since.
Right.
And I felt it, and I walked home, and when I rechecked my heart rate variability, it was balanced for the first time. And then this continued, and it actually went to hyperparasympathetic balance. I got to a point where
too chill.
I was too chill. But it was like what it was like.
He was high without taking drugs.
I was.
Without having any CBD kind of things going on.
Everything slowed down for me, right? Everything slowed down. I walked, I talked. My wife was like, "Something's different." Yeah. And then at one point, my main practice administrative manager, she's a wonderful person. She tapped me and said, "Hey, could we get the old you occasionally?"
Yeah, we need the old Gus.
Yeah, and so I had to turn it back on. But I just say that because the stress is so powerful, and we're taught so many coping mechanisms, mindfulness, breath work, supplements, and those are all helpful. I agree with all of those strategies. But
breathing.
But the root issue is trying to maintain unsustainable lifestyles. I believe our bodies are designed. I'm a spiritual person, and I believe that the concept of Sabbath rest runs through all of creation and definitely runs through us. And, and if we dishonor it, we break down.
That's one thing I'm going to try to implement during the sabbatical, that it becomes a habit, so that when I do come back to the grind, it's already innate. That I'll have maybe some of what you're talking about. Maybe my day ends at 3, not 6. Maybe I take the real Sabbath, just totally take off Sunday, turn this phone off, don't do any work at all.
It's a great thing to do.
I mean, I'm going to learn what I need to do so I don't fall into this same trap again.
Yeah, and that is going to be for you, I think, the major deal. I mean, then from there you...
Because I go when I'm on.
Yeah.
But I need to be off a little more.
You need to be off more, and when you're off, really allow your mind to turn off. You don't have to be
Right.
plotting the next book or the
And
next
that's
thing.
hard because this brain never stops.
It's hard for me as well. But we were supposed to occasionally let go,
Right.
hand the world back to the one who made it, and be okay with just sitting on a rock by
Yeah.
with a good friend contemplating things. You know, we don't have to. Yeah, so it's very important. I think the stress is the most important piece for Jimmy. I think the diets, he could play around with them. He could go, keto carnivore, and then he could go back to more plant. I think in the end the diet he's doing is working for him, but I don't think that. I think as long as he's paying attention to food sourcing, then he's going to be fine with all of these different options. We're also using peptides, and that
Talk about that. We're running a little bit close on time.
Okay, so I'll try to. I went on a little long, and forgive me if I overdid that, but I want people to know it's important.
Sure.
So peptides are newer therapies. They're called biologics. These are compounds that the body actually produces naturally. Short chains of amino acids, growth hormones, a peptide, insulin's a peptide. A number of them have been able to be classified, studied. We know what they do in the body, and some of them have FDA approval for treatment of conditions. Peptides, at this point, we cannot identify any negative impact from peptides because they're natural, and we use them in
Except for flushing when you inject them in, and you kind of get this flushing feeling
you can
all over your
definitely
body.
do that, and you can definitely get yourself bruised up if you're using injectables.
Is the flushing histamine response?
No, I don't think it's a histamine response.
Because that's what John Lemansky thought.
No, maybe it is, but I don't think it's a histamine response.
But I don't get it every time.
Yeah, but no, the flushing definitely
It's like every other time I
can
get it.
happen. Yeah, but so peptides come in different forms. Most are injectable, some are topical, some are oral, and they all have very distinct roles. And so they're targeted, meaning when you put a peptide in your body, it's going to a certain set of receptors, and it's doing a specific thing. And it could be a cellular receptor, it could be DNA that it's unlocking. And the ones that we know serve particular purposes can be incredibly helpful for different reasons. So we have reparative restorative peptides. One of them is this is it right
That's
here.
the newest one you put me on.
Yeah, BPC-157. Now this is an oral peptide. It's actually made by the gastric epithelium. And this peptide, we don't know exactly how it's working, but it produces inflammation, and it does initiate the repair-restore pathways for whether it's connective tissue or in the gut. So there are many people who have chronic gut issues, gut hyperpermeability, even people who've had gut inflammatory bowel conditions that without, follow your doctor's treatment, who use BPC-157 along with a clean diet and fasting and have completely healed their gut without having to take probiotics, without having to do all of the other stuff that you have to do. So this is very good for the gut, but it also can be used for people who've had surgery or an injury to help initiate a more prompt reparative response of tendons, ligaments, cartilage, and it will reduce inflammation.
And a doc has to prescribe this.
A doc
right?
does
You
have
can't
to
just
prescribe. You
pick
can't.
it up.
There is a version of this advertised on the internet by Dr. Seeds. They sell for $40. It's not the actual peptide. It's something different. In the end, it might end up having good evidence, but the actual peptide itself is not. That's not it. You have to have these prescribed. I take this one all the time. I take it. It's expensive, and I pay for it because I do so much with my body. I'm just trying to prevent injury. And some of the mentors for me in genetics and epigenetics, they all take this all the time too. And these guys are Spartan racers and stuff like that.
So that's the fun one to take.
Yeah.
Jimmy Moore is scared of needles, and you,
Yes.
Gus Vickery, have Jimmy Moore sticking himself with 2 freaking needles every day.
Yeah.
Talk about those.
Yeah, so we're using a weight loss strategy, and again, it's not so much about weight; it's health improvement.
I'm loving it.
Yeah.
If that's giving me the benefit.
Yeah, but
Isn't that the $12.95?
yeah,
That's
so
the weight loss,
so
the fat
the
mobilization.
Yeah, the short initials of this are CJC $12.95 and then AOD fragments. These are 2 different peptides. They play 2 different roles. The CJC is a growth hormone releasing peptide. It's a combination actually, and what you're not giving yourself growth hormone. You're giving yourself a little. It's a very small amount, but a signal that will create an increase in growth hormone secretion, a little pulse of growth hormone secretion.
Right.
And you're also sensitizing the receptors to respond to that. And so we'll give this for some individuals just at bedtime. They'll do it 1 dose a day at bedtime. It's a overall wellness protocol. It improves the growth hormone secretion at night. It also can improve deep sleep. So for those individuals not getting deep sleep and having suppressed growth hormone,
Is that why my deep sleep got better?
it might have.
Maybe.
It could have. It definitely can
He's
improve
got the
deep
magic
sleep.
elixir
Yeah.
for me.
Yeah.
I also have been fasting more.
Yes.
Because the growth hormone response, I think it's allowed me to fast more, which the fasting also is improving the growth
further
hormone.
improves growth
so
hormone.
that 0.3 is going to go way
Yes.
higher.
Yes, that's exactly right. It's going to go up. And
I'm
then,
excited to see it again.
Yeah, and then what we're using is the full protocol where you're using both the CJC and AOD fragments because of the amplified weight loss data we have using that protocol. And then twice a day injecting instead of just once a day at night, because you can do a morning injection and an evening injection. And actually for enhanced weight loss, for people who are really trying to change body composition, it's not just weight loss. It's improved bone density, improved lean body mass, improved muscle composition. Now, it won't do this for you if you sit on the couch. You can't just sit and take peptides and hope your body will change.
If you exercise, it enhances the benefits even more.
Yeah, it is an enhancement tool, not the actual primary tool. The primary tool is that you're actually using your body properly and eating properly.
Oh, but Americans want the magic pill.
It's not going to work that way. There is none. Yeah. And
Well, there is a magic pill. It's eat real food.
Eat real food and use your body, right? Train strength, train sprint. Also rest and recover and reduce stress and sleep. But so if you inject morning and night, and then there's an actual protocol where you take the CJC 1295 and you inject it 3 hours after you've woken up while you're still fasting. And those little extra growth hormone pulsations, those accelerate weight loss and improve lean body mass. Or improve your ability to maintain and grow lean body mass if you're creating the signal for that, which is exercise.
I never thought about it, but when I take the injections, it's always in the morning, and it's always in like a full 17, 18, 19 hours of fasting. I didn't realize until you just said what you did that that's actually given that pulse that maybe propels me to fast 5 more hours. Then I go do a workout. Then I eat. And so I'm getting all the benefits. Maybe that's some of the weight loss that's happened since
it could certainly be
July 1.
It could certainly be part of it. When we combine the peptide therapies with somebody who's really doing the lifestyle, it's pretty amazing the results we see. So, Jimmy,
I'm going to take this a lot, you guys, during the sabbatical.
And we're not going to cause harm, right? I mean, we do these in cycles. I mean, because we cycle a peptide for a period of time and then we back off of it for a period of time because the body begins to resist any consistent signaling.
That makes sense.
Right? And so, but there's other ones. Epithalon, we'll play around with that one next, and you can talk to your audience about it. There's a lot of them. Or if you've had a serious injury, you can use something called TB500 and really expedite recovery. Autoimmunity, Thymogen alpha. I mean, the list goes on and on. Dihexa for people with neurodegenerative disorders and inflammation. And most doctors aren't going to tell you about these strategies, but they're very safe and they're more effective than pharmaceuticals, and they're assisting. And
it's natural.
And it's natural. It's you're using compounds your body already makes.
Interesting.
You're just optimizing. So Jimmy's overall plan would be to continue keto carnivore while optimizing it, making it a little bit more of a
liver and road coming my way.
Yeah, he's going to be doing that. He's going to continue his fasting. He's going to continue to monitor deep sleep. He's taking a sabbatical, and he's going to completely rebalance his central nervous system, both through supplements and through sabbatical, mostly through sabbatical.
And heavy lifting.
Yeah, and then he's using the exercise stimulus along with a peptide that will reduce gut inflammation and body inflammation and help with repair, along with a peptide that's going to help with body composition optimization.
And I might eat a few of these along the way.
And I will too. But, this entire plan should result in the next 6 months. We're not going to talk about the weight, but the change in body composition, how he feels. He tends to feel good, but I suspect what he'll say is he had no idea how good he could feel. The rebalancing of the central nervous system and the biometrics. We expect to see a reduction in inflammation, improved lipid cycles, maintained no insulin resistance, optimal reproductive. It's going to be exciting to watch.
I think it'll be fun to come back on here March the 1st, the day I come back.
Yeah.
Come see you.
That'd be great.
On that day. Because here we have all this data. It's not all bad, but it's really not all good. So March the 1st would be the telltale date.
Yeah.
So let's plan on that. We'll run the numbers mid-February, and then I'll come in. We'll time it so that you guys, this is the first thing you'll see when I do come back from sabbatical, coming back and letting that man go, holy crap, what happened? Or, holy crap, did you follow your protocol? Are you sure? No, I don't think the latter one's going to happen.
Yeah,
So.
absolutely. No, I don't think so. I think we're going to see a lot of improvement, and I know that Jimmy's going to be reporting how good he feels. It's going to be great to watch. And, I'm so thankful. I mean, not everybody would share their health data with the whole world like this. I mean, it's, it'd be easy for people to use that in some way against you perhaps or something like that. Most people are very confidential, but Jimmy was kind enough to share this with everybody. and then to share the consultation, because I know that not everybody's going to be able to find a doctor or necessarily afford this level of consultation. But if you paid attention to how we talked through this data, this is how you would be thinking about your data. And if you can find ways to get bits and pieces of it, you could use, the way we looked at this and at least get closer to understanding what you need to be doing for yourself. So it's really cool that you would be willing to share this with everyone.
And I'm happy to do that. And guys, he is available. He started doing more of this personalized healthcare. Go to drgusvickery.com, Vickery.com. And yeah, he would love to see you if you live in and around the Asheville, North Carolina area. But even if you don't, he'll see you remotely, can run all these tests. I just think there's just not enough of you in the world to run these kind of tests. So thank you. We are running out of time. Thank you for joining us. Thank you for going over all the numbers. And yeah, next time we see him on camera, I'm going to be a different man. I promise you that. So thank you, Gus.
Thanks so much.
Thank you, Chrissy. That's it for this episode of Jimmy Rants. Go to jimmyrants.com. You can get full everything. We get the video up later. You can see it on replay. Watch it there. We will be airing this on the Living La Vida Low Carb show soon, so go check that out there. And thanks for hanging around, you guys. This was a lot of fun. Hope you enjoyed it. Hope you learned a lot. You may have to watch this like 10 times to get all the ABC 1, 2, 3 $1 million words. But thank you for joining us. We'll see you again real soon. Bye.